Dear audience and dear scientific committee and our chairman, all of you, good afternoon and welcome to the fifth session. I am Dr. Zaid Atif from Al Yemen. It is a great pleasure to co-share this session with my dear Dr. Mariam from Al Bahrain Kingdom. The session include highly clever speakers. They will present their presentation during the session about cardiovascular disease and drug of cardiovascular disease and diabetes. The first speaker, it is a great pleasure to introduce the Professor Dr. Asher Fuad, working as professor and the head of biochemistry department in Bakaya Medical University in Karachi, Pakistan. Dr. Fuad, research director in Bakaya Institute of Diabetology and Endocrinology in Karachi. He has many activities and many research in the field of diabetes. He is consultant diabetologist, consultant researcher in many research in diabetes and cardiovascular disease and many field of medical issues. His presentation titled by the prevalence of diabetes and cardiovascular disease risk factors in MENA region. Dr. Asher, welcome. The time for you is 15 minutes for presentation and 5 minutes for discussion. You are welcome, Doctor.
Thank you very much. Thank you for this kind introduction. I hope you can see my slides. Is it so?
Yes, we can, yes.
Yes.
Okay. So, Assalamu alaikum, ladies and gentlemen. Greetings from Pakistan and MENA region. Thank you, respected chairperson, for your kind introduction. It's an honor and pleasure for me to be invited by the organizers of this highly esteemed scientific platform. My very special thanks to Professor Jamal and all members of the scientific committee for the event. We have already evident a full successful day, around 2,000 participants yesterday, and we hope and wish to have a similar successful today as well. My respected chairperson, please allow me, before the start of my talk, to pay tribute to my mentor, a visionary legend, an innovator, and a true leader, Prof. Shera. May Allah subhanahu wa ta'ala place him in the highest place of Jannah. Ameen. After the sad demise of Prof. Shera, thanks to Almighty Allah, we are now blessed to have Professor Abdul Basit, who is elected as Secretary General of Diabetic Association of Pakistan, to continue the work on the same spirit and on the same line as has been drafted by him. I am extremely grateful to both these legends for allowing me to serve the region as coordinator for the MENA Region Guideline Committee, for which the latest document is now in the final phase, IDF MENA Region Guidelines. Now coming on to my topic, these are my institutions. I have no conflict of interest to declare. I would be covering my topics in these headings. IDF MENA regions is sharing a significant burden of global diabetes prevalence, with further rapid escalation and increase is expected in the coming years. Exactly 12.8% is the regional prevalence, with around 55 million people in the region, and there are around 45% people which are not diagnosed yet. This is further alarming for the region that they are not knowing about their condition. Similarly, the mortality for this condition is also not good. Around 419,000 deaths are reported in 2019. Impaired glucose tolerance, another important condition. Around 35 million people are at the verge of getting type 2 diabetes, further adding to the problem. Type 1 diabetes, although numbers are not very high, but we need latest and fresh trials in this area for the region. Hyperglycemia of pregnancy, very well covered by yesterday by Professor Shabinaz and colleagues yesterday. 1 in 9 live births are affected by hyperglycemia in pregnancy for the region. When it comes to the prevalence of the region, you can see there are many dark shades showing that 12% or more prevalence for diabetes in the region. Country-wise, the data is showing we have as much as high as 22% for the Sudan, followed by Pakistan, Egypt, Qatar, Saudi Arabia, and Bahrain. All are having more than 15% prevalence of diabetes. So you can very well imagine the amount and the burden of the disease in this region. In terms of the number of millions of people with diabetes, Pakistan with 19.4 million is on the top, followed by Egypt, Iran, Saudi Arabia, and Sudan. Year-wise prevalence for the region, it was quite steady till 2017. It was 9.2%, and then in the 2017 onwards, it start increasing, and we have now currently 12.8 million, 12.8% of diabetes for the region, thanks to the fresh surveys, thanks to the countries who are giving this data. Now to IDF have fresh data for this region. I myself, along with Professor Basid, remain involved for the National Diabetes Survey of Pakistan, for which the figures are now being reflected in the IDF Atlas, and many more countries are getting fresh data for the region. Pakistan and Egypt are leading for the region in the top 10 countries. This situation is very alarming. Pakistan with the number of people of diabetes, 19.4, Egypt at 9th position, and this condition is getting further worsen in the 2030 and 2045. The position for Pakistan is expected to be at 3rd place and Egypt at 7th place. After the diabetes, now coming on to my second part of the talk, cardiovascular disease. This is the global survey on cardiovascular awareness and knowledge among people with type 2 diabetes. The regional finding shows that the people of the region are having enough knowledge for the cardiovascular disease as a disease entity itself and about the risk factors as well. But more sensitization and more awareness are required as the disease burden is very much high for the region, as I showed you in my previous slides. Coronary heart disease in MENA region, the inter-heart study involving 52 countries, more than 15,000 number of subjects in the research, showing that median age at the presentation for first MI was 51 for the region, which is the lowest age of all 9 regions in the study. So it's very alarming that in the people in the young age are getting heart disease, and less than 5% of the all patients were taking any lipid-lowering agent before admission. Further alarming situation. Now comes on to the independent risk factor for the cardiovascular disease. When it comes to the hypertension in the MENA region, 1/5 to the half of the population of the representative countries of the region are having this hypertension, which is a very well-known independent risk factor for the cardiovascular disease. Endorsement from WHO and IDF showing that Central Asia and the Middle East, comprising of our MENA region and Africa region itself, have a large proportion of people with high blood pressure. It comes to the dyslipidemia, a typical metabolic derangement showing decreased HDL level with increased triglycerides, LDL, ApoB and ApoA1 ratio is being represented at the region. The latest data from the region is from Pakistan, just published in 2020. In fact, it's online published. The dyslipidemia is as high as 96%. So very high percentage of dyslipidemia in Pakistan, and not very much different figure from the region. it's up to 55%, the prevalence of dyslipidemia for the range in a review. Obesity, another problem which occurs in the region and is very much high prevalence for obesity in the region. In a review, it's showing that up to 80% of the people are having in the MENA region are obese, and this obesity is across all the income countries, while Pakistan data is also endorsing, and the data from low, middle, and upper middle income countries, all are the similar data showing very high prevalence of obesity for the region. Prevalence of obesity in MENA region is amongst the highest in the world. Women in the region had the highest waist to hip ratio compared to all other regions. The obesity prevalence rates are almost similar among the high and middle income countries. Smoking, another important risk factor, is very much prevalent in the region. People are having 1/5 to 1 or half of the population from different countries are having this risk factor according to the Breathe study published in 2012, showing that smoking and the other related things are very much prevalent in the population. Aggregation of all these risk factors, the metabolic syndrome, endorsing that up to half of the population of the region is having this metabolic syndrome, who are very much prone to getting cardiovascular disease. After the independent risk factors, it's the dietary and physical pattern which can be modified, but unfortunately, these habits are not very much healthy for the region. A comparative risk analysis of the MENA region found that suboptimal diet was the leading risk factor for the cardiovascular disease. Two countries representative for MENA region, it's 48% for Morocco and 72% for UAE. This data shows that they are having suboptimal dietary pattern in their countries. Further alarming when it comes to the sedentary lifestyle for the region, up to 93% in males and 98% in females from the region countries, they are physically inactive. Very alarming, and they are now getting very much prone for the cardiovascular risk factors and disease itself. When it comes to the high burden of the risk factors, definitely the cardiovascular mortality is very high. The region of the Central Asia and Middle East, comprising of our MENA region and Africa region itself, are with the highest rates of age standardized cardiovascular disease mortality. This data has been endorsed by WHO and IDF itself. With all this enormous burden, the health expenditure on the diabetes in MENA region is very high. Currently, there are $25 billion is being spent for the diabetes care, and it will be around 40 billion in 2045. A huge amount which is being spent and expected to be spent in the future years. So this need to be care in future. Non-communicable disease, including cardiovascular disease, account for more than 75% of the total disability adjusted life years. So the MENA region countries clearly shows that the people from these countries are having total disability adjusted life years, and 75% of the total disability is due to the non-communicable disease, including cardiovascular disease. Economic impact of health on healthcare is very high. MENA region countries out-of-pocket spending exceeds the threshold for catastrophic spending, implying that there is a high risk of households getting poorer as a result of paying for healthcare. So this shows that disease burden is high, risk factors are very high, that have a high mortality, and we have a high economic impact of this disease condition. Finally, my final few slides, we have some recommended solution for this increased burden from IDF advocacy toolkit through public health measures. We can go for the primary prevention, prioritization and prevention of cardiovascular risk factors, including diabetes, treatment of the existing disease, legislation and policy making for the relative conditions, through school community-based interventions, obesity prevention through encouraging physical activity, education on healthy diet and addressing barriers in the lifestyle modification can be achieved. Thirdly, involvement and support from the family can be helpful for the region. And lifestyle intervention, last but not the least, promotion of healthy eating and physical activities in the community can be recommended. To conclude my talk, the high prevalence of cardiovascular disease in the MENA region due to enormous rise in the incidence of its risk factors will require a multidimensional team approach to combat the situation. I would like to end my talk on a lighter note, though not scientific, but it's not that diabetes, heart disease, and obesity runs in the family. It's that no one runs in the family. Thank you for your kind attention.
Thank you, Dr. Ashar Jawad, for excellent presentation about the prevalence of diabetes and cardiovascular risk factors in the MENA. We'll open for a question for 5 minutes. Dr. Zayed.
Yes. Yes, Dr. Mariam. There is questions about the prevalence of diabetes in rural area and among female and children in MENA region. Is there data about this issue, Doctor?
Yes, we have data for rural and urban distribution as well, but it's not the same across the region, but the differences in rural and urban settings, which were known previously to be widened, but now we have almost the similar prevalence in rural and urban areas. Some areas we have more prevalence in the females because of the high prevalence of obesity in the region.
Thank you, Doctor. Also, while you present the last slide, the family history, what about the prevalence of family history among diabetes and cardiovascular disease in our region? Have you data?
Yes, family history of diabetes is almost the part of all surveys, but for the sake of time, I wasn't able to include all the risk factors. Yes, there is a definite association of family history of diabetes for diabetes itself, type 2 diabetes. And when it comes to the cardiovascular independent risk factor, yes, for hypertension, obesity, and dyslipidemia, all are having clear associations for family history. Thank you.
Thank you, Doctor. There is no more questions, and thank you very much for your excellent, informative presentation. Thank you, Doctor.
Thank you.
Okay. The second speaker, first of all, I would like to thank the organizing committee and IDF MENA region. It's my pleasure to be one of the moderator in this session and in this important Congress. Our second speaker is Professor Hani Shupar. He will give us about the dilemma of asymptomatic cardiovascular disease and diabetes. Dr. Hani Shupar is currently consultant cardiologist and electrophysiologist in Abu Dhabi, and also former internal medicine residency program director at Al Ain Hospital in Emirates. He serves as director of cardiac arrhythmias and electrophysiology at Landmark Medical Center in Rhode Island in USA from 2003 until 2012. Dr. Super received his medical training at the Faculty of Medicine in our region in Kuwait University. And he's also had awarded His Highness the Emir's Gold Medal with first class honors. Also, he's postgraduate and specialized in completed residency after Kuwait. He was also clinical and research fellow in clinical cardiac electrophysiology at Massachusetts General Hospital in Harvard Medical School. Dr. Super has been involved also in multiple clinical trials, and he's had a heart and currently he had a fellow of American College of Cardiology and Heart Rhythm Society and the American College of Physician and Egyptian American Medical Association. Dr. Super, you are welcome, and the floor for you. Thank you very much.
Thank you very much, Madam Chairman, and thank you really for including a cardiologist in your very important meeting. I think this is really the most important kind of interaction that we can help our patients who have diabetes. Of course, it was just stated by my colleague that the cardiovascular disease burden in our region, as well as the diabetes, is amplified. So I'm going to change the focus a little bit. We will talk about cardiovascular screening in type 2 diabetes, but I'd like to focus a little bit on detection of heart failure in cardiovascular disease. I will mention conventional atherosclerosis. So the cardiometabolic approach really includes cardiologists and diabetologists and nephrologists. And you'll see here a proposed training program that suggests that all of us who are dealing with these diabetic patients should have familiarity with ECG, echo, cardiac CT, plus obesity and diabetes, lipid management, smoking cessation. So there's an integrated approach that's really important now for all of us to learn. So our mutual goals are cardiovascular risk reduction of MI, stroke, death, and now heart failure and renal is very important from the new data that has come from your remarkable diabetes studies. In addition, addressing the glycemic control, blood pressure, lipid, and traditional thrombotic risk. So we all know, and you are also the experts in this, how diabetes affects the cardiovascular system through dyslipidemia, platelets, metabolics, and also endothelial dysfunction, vascular stiffness, inflammation, and oxidative stress. Now, it's very clear that cardiovascular risk essentially is doubled in patients who are diabetic versus non-diabetic. So you see this is an OASIS study. It's actually a conventional mortality study. CV death, new MI, stroke, mortality is all doubled, and new congestive heart failure is also doubled in diabetics enrolled in a conventional atherosclerosis outcome study. And without going into the details, multiple things occur during insulin resistance with glucotoxicity, lipotoxicity, and in addition to the glycemic disorder, the dyslipidemia of diabetes, inflammation, and impaired thrombolysis. So we start initially with assessment of the diabetic patient. This is the ADA guideline from last year, and assess risk of diabetes complications, assess risk of ASCVD and heart failure, look at the risk factors and calculate the 10-year risk if applicable, staging of CKD, and looking at hypoglycemia risk, and multiple things go into this. So it's very important to do risk assessment. Risk assessment in prevention of cardiovascular disease and diabetes, it's very important not to miss it, because most of these patients have no symptoms. They don't really have a physical sign. There's not a single lab test or a single time point that you will have. It's a convergence of detailed assessment, thoughtful investigations done by clever and well-informed physicians that warn of an impending cardiovascular or renal event and can be prevented, and leads to early pre-event medical interventions, reducing mortality. I am not talking about doing PCI. I'm talking about intensive medical therapy. Now, the ACC has in the lipid guidelines identified metabolic syndrome as a risk enhancer that requires intensification of statin. And you know metabolic syndrome better than any cardiologist. Waist circumference, elevated triglycerides, elevated blood pressure, elevated glucose without necessarily meeting the threshold of diabetes, and low HDL. In addition, risk enhancers include South Asian ancestry, very, very, very important in the region, and ankle brachial index. So ankle brachial index is now incorporated in the guidelines as a reason to establish atherosclerosis and intensify lipid hypertension and other treatments. Now, the ESC has taken a more pragmatic approach. Essentially, any diabetic patient more than 10 years duration with no target organ damage, any risk factor is automatically high risk. That means 100% of the patients we see in our clinics. Any additional risk factor or any additional target organ damage or more longer duration in type 1 is equal to having established CVD and very high risk. Just to simplify, the additional factors are proteinuria, renal impairment, LVH on ECG, retinopathy. So any target organ damage in a diabetic patient automatically pushes them into a high-risk group. plus dyslipidemia, smoking, obesity, and age. And in reality, patients with both ASCVD and diabetes are at the AACE guideline extreme high risk mentioned in the ACE definition. Now, going to the ACC back again, they mention in diabetes a patient who had retinopathy, neuropathy, albuminuria, or low GFR plus long duration is automatically at very high risk of ASCVD events. And also they recommend doing an ankle brachial index on a regular basis in our type 2 diabetics to detect the presence of atherosclerosis. And the purpose of this is to intensify all their therapies. Now, the additional factor that you know from the ACC guideline is that it recommends the use of coronary calcium score, but there's a very important caveat. Many cardiologists forget this. If the coronary calcium score is 0, you can withhold statin therapy except if patients have diabetes, have a family history, or smoke cigarettes. So even in the patients who have a no calcium score, you cannot use it to withhold statin therapy, ACE inhibitors, and of course in diabetes specific therapies. Now the dilemma now comes for the cardiologist and the non-cardiologist even more, is that the ADA guidelines recommend stratifying or changing therapy based on the presence of ASCVD or CKD or heart failure. So how does the diabetologist recognize these phenotypes in the outpatient setting, right? In primary care settings, without having a prior history? This is important because cardiometabolic risk starts from prediabetes to diabetes, and it is driven to cardiovascular disease. And I think this is where we have to start finding these patients. And of course, your guidelines and our guidelines have now intersected to recommend specific diabetes therapies that reduce cardiovascular risk, not just glycemic control. So identifying the cardiovascular patient who is asymptomatic is so important. Now, there are multiple aspects of cardiovascular disease in diabetes. Of course, we mentioned oxidative stress, inflammation, insulin resistance. But in addition to conventional atherosclerosis MACE events, heart failure events are extremely important and lead to cardiovascular death. And one of the important stages of heart failure and diabetes together is this. In diabetics, they are at high risk of developing heart failure, and 50% or more have asymptomatic heart failure, the pre-heart failure diagnosis. And many clinical studies have actually shown that 68% of people, up to 68% of people with diabetes had LV dysfunction as early as 5 years after the diagnosis of type 2 diabetes without ischemia at stress testing at baseline. So these patients actually with diabetes have a combination of either reduced ejection fraction with low EF and dilated ventricles, more commonly preserved ejection fraction with LVH, diastolic dysfunction, both of which lead to cardiovascular death and heart failure hospitalization. The other important point is the bad marriage of CVD and DKD. Diabetic kidney disease is very common in this region. In addition to progression to end-stage kidney disease, it actually increases the risk of cardiovascular death 5-fold. And specific drug classes have a benefit, as we know from SGLT2 inhibitor trials. So this is actually the bad marriage of CKD and type 2 diabetes, the outcome of which is cardiovascular death. So we need cardiology, the kidney, and diabetes together to create this bad outcome. And as you know, cardiorenal risk doubles or even triples the risk of heart failure if you have CKD in the presence of diabetes. So heart failure is much more common than you think, and it's actually one of the first manifestations of type 2 diabetes cardiovascular disease in a huge cohort from the United States, 2 million people, right? And as we mentioned, many echo studies will detect anywhere from 50 to 68% of patients asymptomatic who have heart failure, even in the absence of coronary artery disease, but only having diabetes. Now, diabetes, of course, increases heart failure likelihood of symptoms and hospitalization. And in spite of controlling cardiovascular risk factors like hypertension and A1C, type 2 diabetes increases the risk of heart failure by almost 50%. There is a bidirectional relationship, we've mentioned this before, in the setting of which this is called diabetic cardiomyopathy with endothelial dysfunction. And this, of course, is Dr. Verma's famous paper telling us that diabetes causes heart failure, MACE, and renal disease. Now, one of the important insights we have are from the cardiovascular outcome studies, DECLARE, EMPA-REG, and CANVAS. less than 10% of these patients had heart failure with reduced ejection fraction. However, the greatest benefit was reduction of heart failure, wasn't it? This was due to underdetection of heart failure even in these big studies. So the big problem is that type 2 diabetes is a major risk factor for heart failure and is often underdetected in the outpatient setting. So how do we detect it? Do we get an echo on every patient? The answer is actually no. The definition of heart failure, if the ejection fraction is above 50% or has at least an elevated NT-proBNP and some background error, a background disorder. Let me just skip through this quickly. There is a common symptom that is always missed in the outpatient setting. The first symptom of heart failure is actually reduced effort capacity, fatigue, tiredness, and increased time to recover. Now, in the diabetes clinic, we don't normally ask this question. We will ask frequently about chest pain, neuropathic symptoms. But if you ask any of these questions, can you go up one flight of stairs? If the answer is no, doctor, I am tired, I am obese, I am any of these answers, the patient already has heart failure. They're not really asymptomatic. So use symptoms as your screening tool. The next is a very important algorithm that many of us do not know or practice. In patients with these vague symptoms or a prior history of diabetes and CAD, diabetes and hypertension, diabetes and use of diuretics, diabetes and orthopnea PND, and as I said, fatigue, the presence of ankle edema or heart murmurs, if the ECG shows any abnormality, you should actually go ahead by the ESC guideline to order a natriuretic peptide. If it is abnormal or even slightly elevated, an echo and a cardiology consult is required. If it's negative, it excludes heart failure. This is a disease that occurs in 60% of your diabetic patients. In addition, remember this fact. Declining renal function is associated with incident heart failure. So low GFR and increased microalbumin are actually biomarkers of heart failure. You see here patients with CKD and HFpEF or HFrEF have almost double the incidence of heart failure. And microalbuminuria with HFrEF or HFpEF, again, almost double those who have neither microalbuminuria nor a GFR. So you see a patient with CKD due to diabetes, think of heart failure as the other target organ damage. The ESC has actually updated its guideline on NT-proBNP in the outpatient setting. This is 2019. And they tell us that BNP quantifies the amount of myocardial stress or damage. So it can detect systolic or diastolic dysfunction as well. And the important thing in the outpatient setting is that you may have clinical symptoms or not. The ECG is abnormal in diabetic patients in many conditions, in the presence of diabetic cardiomyopathy and elevated natriuretic peptides. And from that, an echo is appropriately ordered and referring to the cardiologist. This was a specific guideline recommendation in the use by the GP and the diabetologists. Any kind of abnormal ECG and the subtle symptoms that I mentioned, lower limb edema, unknown use of diuretics, PND and orthopnea, or just fatigue and inability to exercise should lead to a question. Does this patient have heart failure? At this point, natriuretic peptides can be ordered and the cardiologist will clear up the diagnosis using the echo. Low ejection fraction, normal ejection fraction, stiff ventricle, but all of us know what have we do to treat this patient. Specific therapies that lower heart failure, particularly SGLT2 inhibitors. And this is the position paper, specific recommendation, natriuretic peptide measurements by diabetologists and GPs in high-risk populations such as those with hypertension or diabetes, helps the targeted initiation of preventive measures such as medicine uptitration, RAS blockers, and specifically now SGLT2 inhibitors. So just because in the interest of time, I think I just want to highlight this point. In the outpatient setting, there is a very high negative predictive value and the cutoff point of less than 125 or less than 35 exclude heart failure completely, and higher concentrations require further evaluation. In addition, the randomized clinical studies were actually done in diabetic patients. This is the Pontiac study and the STOP-HF study, both of which showed a significant reduction in cardiovascular events if a BNP was elevated and was reacted upon by echo and intensive medical therapy by the diabetologist and the cardiologist. And with that, I thank you very much. Because the time is short, I'm going to talk only about heart failure prevention with RAS blockers and SGLT2 inhibitors. It's very clear now that the combination of RAS blockers and SGLT2 inhibitors have a very important role in preventing one of the most undetected and yet clinically very important outcomes of diabetes. And therefore, early detection in the diabetes clinic and cooperation with the cardiologist is so important in this particular event. And thank you very much for your attention.
Thank you very much, Dr. Hani. It is an excellent presentation, Dr. Hani. And we are waiting for any questions. While this type of subject have many questions and need answer, either by Dr. Hani or any professor in the field. Now, the last speaker in this session, Professor Antonio, is a researcher consultant in the Institute Investigator in Barcelona and in Milan, Italy. Currently, he is the chairman of Diabetes and Cardiovascular Disease Study Group in Europe. And he has also chaired the IDF Committee of Development in 2008 and in the 2011. Professor Cirillo has been consultant of National Institute Health in USA and a member of the writing committee of the American Heart Association of Guidelines on Acute Hyperglycemia and Acute Coronary Syndrome. Professor Antonio has his stamp in much guidelines, either in Europe or also in USA in the field of heart and diabetes. He has over 500 original paper and self-look chapters. He has many research and many committee as a chair for many committees and members of committees in the IDF and EST. Professor Antonio will introduce his presentation. The subject will under the title, Why Cardiologists Should Not Initiate Diabetes Management. Dr. Antonio, welcome to the session and welcome to the MENA conference. You are welcome.
Thank you very much for the kind introduction and for the invitation to join this very interesting meeting. I have to say that it's quite unfair to speak about why cardiologists should not initiate diabetes treatment after a talk from a cardiologist. So, but I think that we will not fight for sure. These are my conflict of interest. So, okay, we know that the FDA forced the companies to make a lot of studies just to prove the safety of so-called new drugs. And also we know very well what happened. We have evidence that for two classes of this drug, SGLT2 inhibitors and GLP-1 receptor agonists, the evidence is showing that they can really be beneficial in reducing the risk for cardiovascular complications for both, and for heart failure, for nephropathy, particularly for SGLT2 inhibitors. You know, this evidence was over years pushing the continued update of the guidelines. I say that there were two guidelines published last year, which in my opinion deserve to be a little bit discussed. One is the ESESD guidelines, which already have been mentioned. I was on board on behalf of DSD, and there are two aspects of these guidelines which are, in my opinion, relevant particularly for diabetologists. One is that if somebody is already treated with metformin, the second choice is if there is a risk for cardiovascular disease, according to what has been already presented in terms of stratifying the risk, we can prefer an SGLT2 inhibitor or GLP-1 receptor agonist. Otherwise, you can be free to add what you want. And this position is not different from the position that the ADA-ESD had in the new algorithm that they proposed just a few months later, the publishing of the ESC-ESD guidelines. Meaning, okay, this algorithm is even more precise because it's suggesting that if patients with diabetes has a predominant cardiovascular risk, so you can prefer a GLP-1. Otherwise, if there is high risk for heart failure or chronic kidney disease, an SGLT2 should be preferred. So the two guidelines are quite consistent. Where is the difference? The difference is that what to do when somebody is naive, is not treated, it's just at the diagnosis. The ESC-ESD guideline suggested to start immediately with an SGLT2 or GLP-1 receptor agonist if there is a risk for cardiovascular disease. While the ADA-ESD is still keeping metformin as background therapy, and then you can go to add something else. And of course, you prefer in the presence of cardiovascular risk an SGLT2 or GLP-1. Otherwise, you are free to choose something else. So there is this important difference between the two guidelines, what to do in a drug-naive patients. So let's have a look at what could be the next step after metformin. Because in the past, we had some evidence in favor of cardiovascular protection by metformin, but also we have some more recent evidence questioning this possibility. You know, about the possibility, the evidence in favor of cardiovascular protection by metformin, this is mainly coming from the UK PDS. You know, the subgroup analysis of UK PDS showed that in a very small group of overweight people, metformin was able to reduce the risk, particularly for myocardial infarction, and evidence lasting even after 10 years of follow-up. But this is the only available evidence, because if you have a look at the recent meta-analysis, you find, I'm just showing one of several, that this benefit is not confirmed in several meta-analyses. Only one is confirming the possibility that metformin can be beneficial against cardiovascular disease. But methodologically, there is some concern because this meta-analysis pulled randomized clinical trials and real-life evidence, which is, let's say, methodologically is not so correct. But also, we have another issue, because one of the questions against the possibility to start immediately with a drug which is not metformin is because the majority of the people in the CVOT trials had metformin as background therapy. So the proposal, the idea is that you cannot skip the possibility that metformin was playing an important role as background therapy when you added a GLP-1 or an SGLT2. Unfortunately, we have some evidence suggesting that this is not true. You hear from this study from Emparek, it's a post-hoc analysis showing that there is no difference between having or not metformin as background, and has been also confirmed in Canvas, not only, but this evidence is suggesting that having metformin can decrease the benefit on SGLT2. So this is why the ESC-ESD guidelines suggested to prefer to start immediately with an SGLT2 or GLP-1. But you know, our friend cardiologists, they believe that diabetes is a cardiovascular disease. This is a position statement of more than 20 years ago. So the cardiologists try to keep diabetes as cardiovascular disease. Okay, why not? But please do not forget because we have always we were accused to be expert only in glycemia and nothing else, that also glycemia plays an important role, not only for microvascular disease, for retinopathy and neuropathy, but also for cardiovascular disease. And this is true in primary prevention. You see here the very famous UK PDS study, where controlling glycemia was accompanied by a significant increase, of course, after many years, but this was show an important impact in decreasing the risk for cardiovascular disease. And probably this is because the control over glycemia, the strict control over glycemia was started very early in the diabetes, while the other studies were failed to show this benefit. The optimal control started very late. But this meta-analysis is very important because it shows that even in people with diabetes and having a previous cardiovascular event, the control of hyperglycemia can give extra benefit. Meaning that if you anyhow is a good strategy to try to get the best control of hyperglycemia, even somebody already had a cardiovascular disease. And you have to do this by trying to avoid hypoglycemia, meaning that the control of hyperglycemia is very important, but also you must get this result avoiding hypoglycemia, otherwise you increase the risk for cardiovascular disease. So it's clear that the management of diabetes is a little bit challenging. And let's say today, if I will spend only a few seconds on this, it is considered even more and more challenging. It's not enough to control fasting glucose, A1C, but we have evidence that, for example, short and long-term glucose variability are also important as cardiovascular risk factor. Postprandial hyperglycemia is another risk factor for cardiovascular disease. The time that somebody spent in range of glycemia is also conditioning the risk for cardiovascular disease. And finally, as already described, hypoglycemia is an important risk factor of cardiovascular disease. So I think that the control, while it's not enough just to give a drug for the prevention of cardiovascular risk, if you also do not pay attention to the control of glycemia. Is this really an issue? I do not think so. I think that in the next future, the solution is to start immediately with the combination. My colleague cardiologists can agree that we treat hypertension starting with the combination. While in diabetes, we have to go step by step and not paying attention to possibility to combine from the beginning at least 2 drugs, and we can consider to harmonize the glucocentric view and the cardiocentric view in order to choose the best therapy to avoid the risk for cardiovascular disease, but also the risk for microangiopathy. So probably this will be the next step according to the evidence influencing the guideline. So in conclusion, cardiovascular disease is the leading cause of mortality in diabetes, but also we cannot forget how important is the control of hyperglycemia to avoid microvascular complications. And so the optimal glycemic control remains a very important strategy. So probably it's time to try to harmonize both gluco and cardiocentric as the best strategy to reduce the burden of the complication of diabetes. Is this aspect manageable by cardiologists? I think that honestly, this is a false problem. I had the opportunity to work with my colleague of the European Society of Cardiology. I learned a lot, and I believe that the best solution is to work together according to the skills we have in diabetes and in cardiology. Thank you very much.
Thank you, Dr. Antonio. I would like to thank our three speakers in this session in IDF MENA Virtual Congress 2020 for their excellent informative presentation regarding cardiovascular disease and diabetes. Now, if there is time, I have some question which is sent by the
There is
audience.
time, Doctor. Yeah, thank you. There is time.
There is time.
No, we have
We have time.
6
Yeah,
minutes.
first and for second session given by Dr. Hani, there is three questions. The first question is how to screen for heart failure in diabetic patient when echo is not available. This is the first question. The second question, how to approach patient when he has high triglyceride, besides he was well controlled LDL with statin. And the third question, the level of BNP and heart failure according to age, is it different? This is the three questions for Dr. Hani.
Thank you very much. I will very quickly answer the questions. So the last question, I think here is the answer. The cutoff points are not actually age dependent. In the outpatient setting, the number is much lower. So in the emergency room, we use much higher cutoff points. But here it is, 125 NT-proBNP or 40 BNP completely excludes heart failure. Very unlikely to have heart failure. However, if the patient has a low number plus symptoms, they should be referred to the cardiologist and an echo has to be done. The second point is how do you screen the patients without an echo? This is very difficult, but I think because echo is required in the diagnosis, but I think the questions that you have to ask the patient are the clinical questions. Always ask a diabetes patient, can they go up flight of stairs? If they have edema, do not automatically just give them a diuretic. Look for other reasons. Do not assume it's due to amlodipine. Look for other reasons. And if they are having increased fatigue, it's usually not due to anemia or obesity. It's usually due to heart failure. And then the next step actually is to do the ECG. So history, physical examination, ECG. Any abnormality on the ECG, BNP is a very useful test. And then of course, echo. And the last thing, which is a little bit out of our discussion, but if a patient has controlled hyperlipidemia, but diabetic dyslipidemia with high triglycerides, the guidelines are recommending the use of icosapent ethyl from the REDUCE-IT study to reduce atherogenic cardiovascular risk.
There is some question also. Can diabetes cause cardiomegaly? This is one. Yeah. The second question, I will say that the question we receive, how can we detect the heart failure with no blood test? This is the second question. The third question, is there any diabetes medication that should be stopped in patients with asymptomatic or symptomatic heart failure? And the last question, does insulin therapy cause hypertension?
Okay. So what medications to stop? If we detect LV dysfunction, symptomatic or asymptomatic by echo or clinical criteria, then clearly the glitazones have been shown to be adverse in this case, right? So while we use pioglitazone for insulin resistance, this actually has been shown to make heart failure worse. Additionally, one of the DPP-4s, specifically saxagliptin, has a black box warning in heart failure. So this is the drugs to remove. How to detect heart failure without a blood test? So this is mild forms of heart failure. Remember, this is not pulmonary edema that you're going to see in the emergency room. So I think careful physical examination history, but without an echo, you cannot really establish the diagnosis. I think the ESC guideline is very clear on that. You have to have an echocardiogram to know if the patient has heart failure with preserved ejection fraction or heart failure with reduced ejection fraction. So the definition requires an echo, requires a history, requires a BNP. Now, does insulin cause hypertension? I don't think that's a direct correlation. If insulin increases obesity in a patient with metabolic syndrome, then sleep apnea and obesity can be one of the causes of hypertension. It's not a direct cause, but we also know in diabetic patients, they benefit from RAS blockade regardless of the presence of hypertension. So in reality, the ideal diabetes patient is on a RAS blocker, on a statin, on a combination, as Professor mentioned, of metformin, SGLT2 inhibitor, and whatever else is needed for A1C, plus some patients will require some aspirin. I think that's the combination that's going to help save lives in these patients.
Bismillah ar-Rahman ar-Rahim. Hello, everybody, in our IDF MENA Virtual Congress, Diabetes in MENA region. First of all, I want to congratulate the organizing committee and the chair of the region to organize this conference. And I'll be proud to share this session with my dear colleague, Professor Mohammed Toom from Sudan. Professor Mohammed Toom is a well-known in our region figure, not only for diabetes specialty, but also for his humanity and the diplomatic history. You must know that Professor Mohammed Toom was previously an ambassador for Sudan in Norway, and I think in Sweden, and I think he is continuing his diplomatic activity even in non-official manner. So Professor Mohammed Toom have very broad, very long expertise in diabetes in MENA region, and he is now having the Diabetes Association in Sudan and in MENA region to get more and more in the activities. This session will have 3 well-known speakers, and it is a very important session because diabetes in MENA region has special boundaries must be respected. We have some specialities to be shared, and also the cultural and the socio-economic circumstances dictated that we must modulate our treatment management for diabetes according to our circumstances. So this session will take the gold from the old, and this gold from the old will include the metformin, sulfonylurea, TZDs. Every day, you know, our colleagues, that the industry pushing an wide and very fast armamentarium for diabetes pharmacotherapy, but still the old is the gold, as we shall see in our session. And now I handle the session to my colleague, Professor Mohammed Toom from Sudan, to introduce the first speaker. Professor Mohammed Toom.
Thank you very much, Dr. Misbah, for this nice introduction. And thank you, all of you, for joining us on this session, which is going to shift to the pharmacological oral management of type 2 diabetes. I had the pleasure to introduce the first speaker in this exotic title. As Misbah mentioned, that the old is gold. But at the same time, I can say that the new is diamond. So we don't know really which one is more richer, but we will see. I mean, وعندنا مثل ثاني بالعربي الأولى تحلى ولا حي بالشكل. Let us see where are we going to go from metformin, and Professor Jean Daniel Lalois is going to speak about updating us on metformin. Professor Jean Daniel Lalois is a head department of endocrinology, diabetes mellitus and nutrition at Amiens University Hospital. He's in charge of nutrition teaching program at Jules, excuse my French, as Jules Verne University, Faculty of Medicine. has number of publication more than 130, and he has 5 books about philosophical approach to nutrition and patient education. You are welcome, Professor.
Okay, many thanks again for the kind invitation, but has some problem. The problem is it still possible to provide new information about metformin? My answer would be perhaps, and perhaps even we will have some scoops. So first about metformin in patients with diabetes. With regard to mechanisms, everybody is aware about the action on mitochondria, and in particular on the respiratory chain complex 1. But if we have a sharper focus, we would speak today about the gut, because metformin acts primarily on the gut and in particular via GLP-1, either directly or indirectly through decreased absorption of bile salts and or change in composition of microbiota. What about renal failure patients? Until rather recently, the positions were, I would say, polarized, yes or no. But my position is yes, perhaps, provided the dosage is adjusted to the renal function. And I would add, the problem is not the severity of CKD, chronic kidney disease, but rather the stability of the kidney disease. This is why we conducted in Amiens 3 complementary studies. The first one was a dose-finding study with metformin at increasing dosages to test, this time in a longer term, metformin at a fixed dose over 4 months, and the end with a PK study. So let's have a focus on the main study, the chronic metformin treatment with 3 dosages, either 1.5 gram in CKD 3A, GFR between 60 and 55, CKD 3B, GFR between 65 and 30, and CKD 4, GFR between 30 and 15. And to be as honest as possible, I present here all individual data with each month of the study over 4 months, and you see a remarkable stability of metformin levels throughout the study. Red dots indicate the patients with a little bit elevated lactate level, and what is important, that there was no correspondence, no correlation between lactate and metformin levels. This is upon these results that the European Agency and that the FDA have changed their recommendations regarding CKD. What about CV outcomes? Everybody is aware again about the UKPDS. But you know, we have now qualitative methodologies looking for CV outcomes research to test some hypotheses, non-inferiority or even superiority. This is the case, you know, for liraglutide. This is the case, you know, for the empagliflozin. But does it mean we have to throw away the UKPDS? Does it mean that cardiologists should prescribe, I would say, modern drugs, while diabetologists are continuing to prescribe an obsolete drug? I would say no. Because metformin acts on the main determinants of the vascular pathology, of the vascular disease, and with an important point, a reduction of all-cause mortality. Also, I have to be cautious because it's true that studies were mainly observational studies, as it one, but it is impressive. because in only 2 years, we show a huge difference between patients with diabetes and atherosclerosis or without atherosclerosis. But we have to reason in absolute and also in relative terms. This is why we may compare here patients treated with metformin or treated with sulfonylurea compared to non-diabetic subjects. And it appears, again, on the basis of observational data, that it was like if metformin withdraw the risk inherent to diabetes. It is not the case for sulfonylurea. What about lactic acidosis? We have a problem, I would say. The cases are either metformin-associated lactic acidosis, or induced lactic acidosis, or unrelated lactic acidosis. And when we don't know anything about metformin levels, we should speak about lactic acidosis in metformin therapy, no more, no less. This is a recent review. The generic term was MALA. Again, when we don't know metformin levels, we should speak about lactic acidosis in metformin therapy. The general case is that of a general disease provoking lactic acidosis. In other cases, metformin intoxication or the equivalent with metformin accumulation in acute renal failure. This is MELA, metformin-induced lactic acidosis. And finally, MALA appears as a small proportion of the global cases of the so-called MALA. In fact, a scoop is to say that MALA, virtually at least, does not exist. Why? Look at this case. We have here acute pulmonary edema plus massive metformin accumulation. The combination, that is the true MALA, but renal function was normal before the event. Renal function was normal after the event, so that the true sequence was pulmonary edema leading to MELA independent, and only secondarily MALA. What about patients with or without diabetes? Nephroprotection first. You know perhaps that metformin is an anti-calcifiant agent. Here are calcifications, and in a dose-dependent manner, you see a disappearance of calcification in vitro. But what about in vivo? Let us see in rats. You give adenine to provoke renal failure and to provoke finally renal calcifications. It is important for the global prognosis of patients with CKD. Here is a confirmation in vivo this time. There was no calcifications in rats treated with metformin. But is it a direct effect? No, because, surprise, there was no occurrence of renal failure. This is a remarkable renal protection, and this is why we are now conducting in Belgium and in France a trial in non-diabetic patients with the hope of showing the nephroprotection in those patients. What about geroprotection? Metformin retards aging in this small animal, and that again in a dose-dependent manner. This is why we are waiting for the result from the 10 trial to be simple in Alzheimer's disease. And cancer. Finally, metformin acts as a cellular protector. And surely the mTOR pathway is important because of the interaction between cell and environment. And what about antimicrobial today? This is a diabetes story. But do we remember that biguanide was first launched to treat virus infections? This is why I studied from the French cohort, Coronado study, if there was a difference or not between diabetic patients treated with metformin on admission to hospital or not treated with metformin on admission to hospital. And this is a huge difference in terms of mortality between the two groups. But we should compare like with like. I say our study groups were not comparable. Here, non-metformin, here, metformin, and we don't have the same age. We have less rate of complications in diabetes treated with metformin. But we have applied the proportion score to compensate for these differences. In addition, metformin-treated patients had a more severe disease because of a longer period between the onset of symptoms and admission to hospital. And this is our important discovery, the rate of mortality on 1/3 lesser in metformin-treated patients. So is metformin poised for a second career as an antimicrobial? This is a case, I remind, for these different kinds of infections. But we have to pay attention, I would say, about viral information. Let us see this publication. The series was rather short, and instead of having an odds ratio in favor of metformin less than 1, in this table you see more than 4. Here is a very important and large study, but BMI was lacking in the huge majority of cases, but other characteristics were lacking again. Therefore, the propensity score analysis could not be done in the huge majority of patients. And finally, metformin prescription was not examined on admission to the hospital. And now, dear colleagues, a look to the future, perhaps for a new conference. And many thanks for your attention.
Thank you very much indeed for keeping with the time. And now we open questions. I don't think I have received any questions so far. So probably we can have it at the end of the session.
We'll proceed. We'll proceed to the second speaker.
Yeah, I would like to introduce you, Misbah. Dr. Misbah Kamil, my brother, will introduce the second speaker. But I'd like to introduce Dr. Misbah. Dr. Misbah is a consultant general physician and endocrinologist from MENA University, Egypt. He's the vice president of diabetes for the Asia Study Group, and he is the founder and secretary general of Upper Egypt Diabetes Association, UEDA. He's a member of Diabetes and Ramadan International Alliance, DAR, and he has conducted wide research in this field. Dr. Misbah, can you proceed and introduce the second speaker, please?
Thank you, my dear colleague and dear brother, Professor Mohammed Itoum. And now it is very honoring and very pleasure to introduce my dear friend, Dr. Mohammed Hassanin. He is a consultant in Dubai, endocrinologist, and he also have a very effort to get this conference to the site, and I congratulate him for the organization and for the scientific effort. Professor Mohammed Hassanin is a very old and dear friend, and have his topics always related to not only diabetes and Ramadan. He's not Mr. Ramadan, but he Mr. For diabetes and scientific activities all over the region. So sometimes we are calling him Mr. Ramadan, but he's not Mr. Ramadan only. This only one aspect of his endless activity, and he always getting to the point. So the topic will be an old one, but I think every one of us use sulfonylurea, and sulfonylurea since about 1948 introduced to the market and still working in our region, although the armamentarium of the drugs increased and increased. But Professor Hassanin also has his own study for Ramadan and sulfonylurea, and he will add to us more and more about sulfonylurea in this session as the gold standard for diabetes management in our region. Professor Hassanin, please, the floor is yours.
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. Thank you very much, Professor Misbah and Professor Tom. It's a great pleasure to have the session chaired by yourselves, and I would like to congratulate the whole MENA region, IDF MENA region, for such a successful conference. Let me get to the point of the role of sulfonylurea, and is it a gold or not, whether it's true or myth. I do like very much the Arabic saying of Dr. Muhammad Ali Tom. I will just modify it slightly to prove that القديمة تحلى عشان هي أحلى, or perhaps those of you who do not speak Arabic, that the older person is better because she is better. So I will go quickly through my objectives, looking into the role of sulfonylurea in current as well as international guidelines, the pros and cons of sulfonylurea, and trying to dissect whether they're all the same or not, and with a conclusion. Of course, this is done from the perspective of us in MENA region. So the question why we treat type 2 diabetes is basically to provide two things: better quality of life that is free of diabetes-related complications. Of course, quality of life is crucial, and sometimes that's precisely just to improve hyperglycemia. But on the long term, improvement in hyperglycemia plus specific drugs have an impact on complications. We all know the latest recommendations. The previous beautiful session by my colleagues have addressed the cardiovascular, the high-risk patients, and it is now well established. For the high-risk patient with atherosclerotic cardiovascular disease, or for chronic kidney disease, or those with multiple risk factors, they need an SGLT2 or a GLP-1. But the reality is, metformin with sulfonylurea were the highest drugs in both arms. So when you look here into sulfonylurea, into the various GLP-1 studies, as well as in the various SGLT2 trials for cardiovascular outcome, latest studies that relates to this, you will find the least inclusion of sulfonylurea was 29%, the highest was 51%. On average, we are talking about 40%, although these patients have cardiovascular problems and have long duration of diabetes. So when we look into the reality, the Discover study is really quite a beautiful study. I thank my good friend and colleague Kamlesh Kunti, who is an author on this paper. Kamlesh and his colleagues looked into 11,000 persons from across the globe onto the SGLT2 criteria of the studies. How much does it apply to our current diabetes cohort? So if you were to look into the Middle East and Africa, which including 2,600 persons, for the MPEREG inclusion criteria, as well as the VERTIS, which is identical in design, only 6%, because they needed to have previous event. If you look into the declared TIMI, which included people with high risk and not necessarily with cardiovascular disease, it goes up to 32%. And that means that the vast majority of our current patients that we see every day are not eligible to the studies of the SGLT2 inhibitors. The same is more or less with the GLP-1 studies. So I reflect here on our Emirates Society guidelines that we published earlier this year, beautiful guidelines published in Dubai Diabetes Endocrine Journal. And here we said for the moderate or the low risk category, you can use any of the 6 classes of drugs equally. We did not put a hierarchy among one or the other. We advised colleagues to consider efficacy, risk of hypos, impact on weight and cost. The only specification was for insulin for those with an HbA1c above 10%. So we need to look into the sulfonylurea evidence of reduction of macro and or microvascular disease complications. Of course, the UKPDS is a study that has included in the biggest arm of it, the sulfonylurea and insulin arm. And that arm proved from the first publication how efficacious that type of therapy for microvascular complications. The myocardial infarction was marginally out of statistical significance, but the legacy of the study 10 years on in this was the myocardial infarction statistically quite significant. So many years back, over 20 years back, we know about the impact of glycemic control using sulfonylurea such as glibenclamide or insulin. The latest breakthrough for sulfonylurea is the Carolina study. The Carolina study is a study not done by a sulfonylurea company. It is done by the company responsible for linagliptin. They were very brave and they did not want to compare with a placebo. They compared with a very efficacious modern sulfonylurea such as glimepiride. And they did not see superiority. In fact, it was identical when it comes to the cardiovascular outcome. And this is really a big cornerstone for sulfonylurea because for many years, there were so many people saying sulfonylureas are not good for the myocardium. And here we have a specific evidence of parallel arms comparison showing that it is no worse and no better than linagliptin, one of the important and modern DP4 inhibitors. And we also have the data of ADVANCE looking into gliclazide MR on the renal outcome, which eventually impact the mortality. And on this, we had lots of very good positive effects of the intensive control with the arm using the gliclazide MR on renal parameters. So really, we have plenty of evidence that shows that microvascular complication is there, macrovascular complication is either safe or it is there as well. What about efficacy and durability? Well, I'll show you 2 recent studies, the ADVANCE. In ADVANCE, the study lasted for 6 years. And as you can see here, those who had an HbA1c above 10, their HbA1c was reduced by 4%. Those that HbA1c was between 8 to 9, it was reduced by 1.7. So clearly, it gets your patient to where the target should be, more or less. As for durability, now here is still again the Carolina study. And as you can see here, here is the glycated hemoglobin. And the study was for 6 years. Here is the number of weeks, 256 weeks. And you can see, starting with both arms, the green, the darker green is the linagliptin, the lighter green is glimepiride. And those who often accuse sulfonylurea about losing their efficacy, well, you can see in the study the efficacy of the DP4 inhibitor and the sulfonylurea glimepiride are almost identical. This line is 7, when this line is 7.2, the difference between them is 0%, as you can see here. So this is really quite important. I'd like to quickly move to cost. And people think that cost is not important, or maybe it's for the poor man. Well, I can tell you for certain, I work in the Gulf countries where wealth is good. But I can assure you that even in Gulf countries where the economy is strong, we have to think of cost, and not every patient is able to be prescribed the expensive drugs. And I here share with you the cost in Saudi Riyal for the cost in Saudi Arabia, and in Egypt in Egyptian pounds. I left them in their own currency so that the audience can reflect whether they are from the Gulf or from Egypt on the cost. So you can see here, the most expensive sulfonylurea comes at 500 riyals per year. That is a third of the cost of a DP4 inhibitor, a quarter of the cost of an SGL2, and less than 10% of a cost of a GLP-1. And the same would apply if you were to get the drug from Egypt. In fact, the cost here, I phoned a colleague today, a pharmacist today, and he phoned me with the cost from his own pharmacy. So I'm sorry, I'm not picking on specific drugs, but I wanted to make the job short. So diamicron MR, the branded name, is 600 Egyptian pounds per year. Januvia is 3,700. Forxiga is, sorry, this is per month. So that's, you multiply it by 12, is 5,000 Egyptian pounds per year. And Victoza per year is 21,000 Egyptian pounds. So cost is really quite important. So one would say, okay, you told us about the efficacy and you told us about the cost. They are important points. But hypoglycemia, according to the ADA, incidence is moderate, and there is also weight gain. And let's review that, because I would like to remind you, the sulfonylurea quite prevalent in the States is glibenclamide, which is not very frequently used nowadays. And many people quote this study, sorry, not that slide, with the comparison of hypoglycemia in the different glycemic control arms. And they fail to tell you very important points. This is major hypoglycemia in people who achieved intensive glycemic control of 6.5. And in fact, I will be very happy if my patient reaching an HbA1c of 6.5 to get 0.7 annualized rate of major hypoglycemic episode per year, because that's not very frequent, considering the efficacy of the drug and also the cost of the drug. So to put it into perspective, you will treat 1,000 persons to get 7 with 1 episode per year of major hypoglycemia. So this is really quite important to put into perspective, because when you look into the latest data published about the various drugs, and actually this is published 5 years ago, where Kamlish and Melanie Davis are the co-authors, looking into over 500,000 persons from 46 different studies of prescriptions of 1 to 10 month duration. And in there, they found that mild to moderate hypoglycemia in insulin risk is 0.52. And for sulfonylurea, it is 0.3. So the difference is there quite big. When you look into severe hypoglycemia, the risk for insulin is 0.2. For sulfonylurea and also for non-sulfonylurea, it was identical at 0.05. So there was no major difference between the modern sulfonylureas they found in this 500,000 cohort and non-sulfonylurea users. And indeed, it looks like we are concerned about hypoglycemia far too much than what is in reality in type 2 diabetes. I would like here to share with you our study done in the MENA region. So this is pure data coming from our territory. And here in this particular trial, we looked into 1,750 persons. 776 of them were on sulfonylurea. The majority of it, 55%, was glimepiride, 38 was glycoside or glycoside MR. And the hypoglycemia rate in normal days, 4 weeks before Ramadan, so that's Sha'ban, that's normal every day, is 2.1, not on sulfonylurea, and 2.6% on sulfonylurea. Hardly any difference. Yes, there was a difference when they fasted. The rates of hypoglycemia went up to 9.2. But that, as I said, was not purely one specific drug. As Professor Misbah said, we'd recently this year had the publication of the dimicron MR study in Ramadan, where we looked into people in their 50s with diabetes duration of 5 years or more with an HbA1c that is reasonably controlled at 7.5. Interestingly, only 6% of them have established cardiovascular disease. And when you look into rates of hypoglycemia, you will see it's 0.2% in normal days. And when you look into Ramadan, it is 1.6%. When you look into severe hypoglycemia, it is 0%, whether before Ramadan or during Ramadan. So really, this gives me great confidence that modern sulfonylurea have low rates of hypoglycemia regardless of the problem. Then we come to the second point of weight. Weight was calculated based on other older sulfonylureas. Weight gain in advance was 0 kilograms over 5 to 6 years. And let's look into the Carolina again, the very important study that compared—
2 minutes.
Sure. Compared DP4 inhibitor to linagliptin. And as you can see here, over 112 weeks, there is hardly any difference. DP4 inhibitors lost more weight, but the difference was 1.5 kilograms. So in essence, ladies and gentlemen, my conclusion is that modern sulfonylurea, such as glycoside MR or glimepiride, have evidence of efficacy and complications. They are highly efficacious. There is no weight gain with glycoside MR or marginal weight gain with glimepiride, with low rates of hypoglycemia, and they are very cost effective. And with this, I thank you and stop my presentation. Thank you very much.
Thank you very much, Professor Muhammad Hassanin, for your elegant talk for this very important topic of sulfonylurea use as a gold standard. And I think you elegantly showed us that hypoglycemia in reality must have many aspects, not only the drug used, but also what is the circumstantial, what is the background, what is the education, and what is the magnitude of hypoglycemic problem. It is mainly for the severe one. We have one question from the audience about the sulfonylurea as a second line for treatment, especially after the guidelines of ADA and ACC, and I think you will enlighten this issue for the use of sulfonylurea as a second line, in spite of some guidelines going on.
Well, thank you very much, Professor Misbah. I have no problem to have sulfonylurea as a second line therapy in specific groups, as long as they do not have cardiovascular disease or renal problems where SGL2 or GLP-1 will be indicated as the second line. I'm quite happy to include sulfonylurea in my therapy. I've shown the evidence, the efficacy, the low rates of hypoglycemia, the weight neutrality or marginal weight gain, as well as the significant cost effectiveness. If the individual is sensitive and develop lots of hypoglycemia, then we can always switch to an alternative method.
Yes, I only
thank you very much.
Add to your, talk. Yes, okay. We will handle the microphone to my colleague, Professor Mohammed Toom, to introduce the last speaker. Professor Mohammed Toom.
Yes, because of the pressure of time, I really would like to introduce the last speaker of today. Probably we can have some time if the organizers allow us for questions. The last speaker is Dr. Al-Amin Abdelkader. He's the new generation of the Sudanese Emirati players. I'm giving him actually a nickname of a very well-known football player, Ahmed Salah, because he's running very fast. So
it is ours. It is ours.
Yes, he's yours. Yes, he's yours, and of the Emirate as well, United Arab. So we are really proud of him to be yours. So he's endocrinologist at Dubai Hospital, and he's a member of various regional groups and conference, and he shared many conferences. And he's the Secretary General of the Sudan Diabetes Association, the Gulf chapter, and he's also active in the Diabetes and Ramadan of Dr. Misbah and Professor Muhammad Hassanein. So the floor is yours, Dr. Alamin.
Thank you very much, Professor Muhammad Ali, and I'm delighted to be presenting here under your custody in this session. And I'd like first to convey my thanks to the organizing committee for asking me to be part of this elegant panel. My talk today will be the role of TZDs in the current diabetes management. And this will pile up and the evidence and reconfirmation and anchoring that the old modalities might be useful in the current clinical practice. I have no disclosures, and I will not be discussing any off-label medications in this presentation. What I'll be doing in the coming 15 minutes or so is just to refresh the memory about the diabetes pathophysiology, and it hasn't changed in the last couple of decades. And will stress on the old modalities might still shine and give the golden look and effectiveness. And I'll just go quickly through the evidence of TZD's function and sometimes the edge on other hypoglycemic agents, oral agents, and what's the place of TZDs in the current diabetes management guidelines. Around 500 years ago, Leonardo di Sera Pier da Vinci accomplished this beautiful drawing, the Mona Lisa. And he didn't know at that time that the Mona Lisa will transform and will disfigure to this Mona Lisa of the 21st century. So at that point in time, the obesity was not a true clinical or medical problem. But now obesity, diabetes, and obesity-related issues are the cornerstone of our daily clinical practice. And this has been elaborated in multiple and various data. This is a couple of United States epidemiological or anthropometric studies that showed the major transform in the average weight of the people at age around 18 years, American, just normal, healthy people. So there was a jump in around 100 or 150 years from the average of weight from around 60 kilograms per person or in average person to around 76 kilograms in the average 18 years old American. That was just in 100+ years. And we can see the jump in the pivotal area between the 19th century and the 20th century, a 7 kilograms jump in the mean. And again, early in the 20th century, a 6 kilograms jump in the mean. So by now, almost 25% of each and every group of 18 years old American may be at the edge of obesity. So obesity is becoming a real problem that we face in each and everyday clinical practice. I'm sure all of you have seen this gentleman which has been presented multiple times in obesity-related or diabetes and obesity-related talks, but it tells the story that our problem is not the subcutaneous obesity. Our problem is the visceral obesity that lies in the viscera, in the liver, and in the skeletal muscles. So that should be our target in tackling metabolic-related issues. And this visceral diabetes can be well taken or well speculated by the waist circumference. This is why the waist circumference is one of the modalities to diagnose the metabolic syndrome and the risk even for the future cardiovascular insults. And that was solidly confirmed by various data and trials. The waist circumference is directly proportionate with the visceral diabetes, adiposity or fat content. And the problem with this visceral obesity is not only the waist circumference and the possibility of metabolic syndrome and diabetes. In fact, the intra-abdominal adiposity is strongly associated with very high vasculopathic chemicals or components like the free fatty acids, the tissue necrosis factor, interleukins, and so on and so forth. And we are solidly agreeing that all these inflammatory markers or inflammatory chemokines might be related to a future cardiovascular risk. So the higher the high sensitive CRP, the higher free fatty acids, the higher secretion of adipokines that's inversely proportionate with adiponectin, increases the insulin resistance and inflammatory process and increases the cardiovascular risk. This is a complexity of how the metabolic syndrome leads to atherosclerosis. So we need to tackle multiple points in this pathophysiology. And this is an old drawing that showed the risk of cardiovascular disease that starts as early days of the pre-diabetes state. So we don't need to wait until the patient becomes diabetic to tackle his cardiovascular risks. So the risk of cardiovascular disease starts here at the early phase of pre-diabetes state. And the risk of hyperglycemia-related cardiovascular risk starts here. So we have all this duration, which might go up to years before diagnosing diabetes, to work on it to prevent future cardiovascular disease. And this definitely goes because insulin resistance will not stop when we diagnose diabetes. What I call the multi-station tram line is the diabetes-related areas that we need to work on or work at. The pre-diabetes phase, insulin resistance, pathology itself, the diabetes itself or hyperglycemia, the fatty liver related issues, and the diabetes and the risk of future cardiovascular disease. What I'll be talking about today, TZDs, is tackling at least touching each and every one of these tramline stations. So pre-diabetes, as far as the pre-diabetes is concerned, this is an old study of, it's called ACT Now. It has been published around 10 years ago, where the TZDs or pioglitazone showed marvelous reduction of occurrence of diabetes in patients with pre-diabetes. So they recruited, it's a randomized control trial comparing pioglitazone versus placebo in preventing diabetes in near future. And pioglitazone managed to reduce the occurrence of diabetes by 72% in just 4 years. And that could have been continued further if the study got prolonged. So pioglitazone, if it's initiated earlier, it might even prevent the diabetes from happening. And that was not a single study. It has been replicated multiple times by the tripod study, which reduced the occurrence of diabetes by 52%, 62%, 62%, and 70% in different studies. So TZDs without hesitancy may at least delay the occurrence of type 2 diabetes. And that's what led the American Association of Clinical Endocrinologists to recommend thinking or considering TZDs even in a pre-diabetes state if the patient is having 2 pre-diabetes points. That's either impaired fasting glucose, or impaired postprandial hyperglycemia, or impaired HbA1c. So if the patient is having 2 of those, metformin was not enough or intolerant, so consider TZD or GLP-1 agonist. However, this recommendation is anecdotal in the ACE guidelines. It has not been supported by other guidelines. So it's left for the institutional expertise or the institutional protocols. Insulin resistance. Probably I'm proud to join a big bunch of diabetes community, thinking that the only insulin sensitizer in diabetes management paradigm is the TZDs. Whether we are using them or not, that's a different story. But neither metformin or GLP-1 receptor agonists have shown the fancy effect of TZDs in improving the insulin sensitivity. And that takes place at different stations, skeletal and cardiac myocytes, adipose tissues, and the liver cells. And this collectively increases the sensitivity of those tissues to insulin, and more glucose uptake, more free fatty acids uptake, and less consequent cardiovascular and metabolic jeopardies. Diabetes, probably all of us who have practiced and used TZDs, we know it's one of the strongest oral hypoglycemic agents. And they meant to take this slide from a clinical trial of GLP-1 receptor agonists. So it's not by a pharmaceutical company that produces the pioglitazone or any one of the TZDs. And it showed that TZDs may reduce the HbA1c by 1.6% at week 26. It's better than the, sorry, excuse me, better than the exenatide, the weekly one, better than the sitagliptin, and better than metformin. So diabetes and cardiovascular disease. Now, no diabetes talk goes without touching on the cardiovascular issues. That was one of the early studies that assessed the effect of pioglitazone on cardiovascular risk reduction. This is the proactive study, over 4,000 patients, continued for 3 years. It did not meet the first time or the primary composite endpoint, which for a reason they included the coronary revascularization, leg amputation, and revascularization of the leg, which was in thought of many researchers that was not appropriate. Anyway, the primary MACE reduction was not achieved, but however, the secondary endpoint, which is a death, non-fatal MI, and stroke, has significantly been reduced using the pioglitazones. And more nicely, in the post-hoc analysis, in those who had a previous cardiovascular disease or previous stroke, the risk of having non-fatal stroke was reduced by 47% at year 3. That was again replicated in a newer study that has been published a couple of years ago, over 3,000 patients, a recent CVA or TIA that was quite courageous protocol, but they were insulin resistant and not diabetic. That despite that, they were not hyperglycemic, and with the effect of pioglitazone on vasculopathy process, the risk of cardiovascular disease reduced by 24% in 4 years. And that was hilarious in myocardial infarction reduction, 33%, and acceptable range of 18% in the stroke reduction by 3 years. That's what led multiple international guidelines to put the TZDs in the second line. However, it's always come with asterisks or a notification on the edge that mean the side effects. So TZD could be the second liner after metformin. Probably metformin will come down to this line in the future, we don't know. And the ADA guidelines in 2020 put the same TZD could be the second liner with the SGLT2, GLP-1, or DPP-4 inhibitors if the patient does not have cardiovascular or renal risk or current disease. Everyone will be waiting for the safety notes that we know TZDs doesn't come without side effects. Usually, they may tend to lead to weight gain, fluid retention, distant fractures, and bladder tumors. I'll start with the bladder tumors. It has not been solidly shown in any of the longitudinal studies. One of the study, the proactive study, the initial one, showed higher incidence of bladder cancer. However, the continuation of the study for 10 years did not show any edge or did not show any higher risk of bladder cancer in this group. The IRIS study have shown again no higher risk of bladder cancer. It was not significant. A bit of higher risk of bone fracture, that was distal bone fracture associated with falls and postmenopausal ladies. heart failure, diabetes, TZDs associated with fluid retention should be avoided in patients with an acute current heart failure, but it does not cause heart failure because echoes were normal in those studies. And with that, I'd like to summarize my talk by just stressing on that type 2 diabetes is a demanding disease and all weapons might be needed at some point of time. TZDs tackle a pivotal pathophysiological complexities in type 2 diabetes. With proper patient selection, TZDs may reduce hyperglycemia, insulin resistance, cardiovascular disease, as well as fatty liver. Small doses carries a lower risk of side effects, and bladder cancer has not been consistently proven against pioglitazone. With that, I'd like to thank you very much and happy to answer any question.
Thank you very much, Dr. Al-Amin. And it's a good presentation. And thank you all the speakers. To finalize the session in 1 minute. But before that, I would like just to ask for half a minute. It was about replagnide. It has not been mentioned as a glucose sensitizer. Where about in the guidelines? But maybe you can.
Sure. Well, thank you for the question, Professor Muhammad Ali. The replagnide as a short-acting secretagogue, they also do have a role. The rates of hypoglycemia are low, their impact on weight is low, and as we used to learn when we were younger doctors, that they are the basal bolus of the poor person. So you can adjust the dose according to the meal size. So they certainly have a role, but the reality is the actual practicality and use is getting less and less globally. But I don't have a problem to use them as an alternative to sulfonylurea.
Yes. Thank you for all the speakers and my dear friend, the chair, Professor Mohammed Toom. We have enjoyed this session with the elegant speakers for very important topics in our MENA region and in the low socioeconomic states we are going on. And with this, I want to close the session and congratulate all the organizers and the chair of the MENA region for this fascinating program. Thank you very much.
Good morning. So actually, my part of the speech is much easier than the rest of my friends. Here we're talking about a medicine that you know, we always use as a baseline, as a standard. The metformin. Of course, I work in DHA, Dubai Health Authority, and for that reason, this is a disclaimer: the part that this is not a DHA-related presentation by any stretch. And so when we come to this part of the talk, actually, we're going to touch on earlier stage, which is mainly the pre-diabetes and diabetes. So, you know, we know diabetes has been very prevalent, especially in the Middle East. And, you know, we know from the adult population that typically you run somewhere in the 12 to 20% plus minus as prevalence. But on top of that, of course, we have very high rate of overweight, and we have to remember ethnicity is important. So here the population is, once they have some increased weight, there's more risk of getting the comorbidity, the diabetes, the high blood pressure, and the high cholesterol. And so in our population, the chance of to have what's called healthy obesity, or somebody who's overweight but doesn't have complications, much less, most likely in the 15% range, compared to Caucasian, which run about 35%. And so as we get the weight issue, we get the diabetes, but even prior to that, we get the pre-diabetes. Now, this numbers here you see from different countries is not necessarily a correct numbers. Most likely it's underestimation, because again, to do it, you have to do a really nice, well-controlled. You have to do it on all healthcare. You have to do OGTT to screen for diabetes, because if you only depend on the fasting, you are going to miss a good portion of diabetic and pre-diabetic. And of course, the glucose does fluctuate, so the fasting glucose is not always the same. And even the result from the glucose tolerance tend to be non-reproducible all the time. So it's not like every time you're going to get the same result. And so, you know, where all that start? I mean, we have diabetes, we have pre-diabetes, but we have to remember that even pre-diabetes, I mean, prior the time of the diabetes and the pre-diabetes patient become insulin resistant, they start having beta cell loss and 5 to 10 years before that. And about 5 years before the diabetes, actually, they may start having microvascular complication. And we would say, well, diagnosis of diabetes criteria is the glucose, the OGTT, and the A1C at which people get complication. But we have to remember that the average duration of diabetes by the time of diagnosis is a little bit over 4 years. So you're going to have a good percentage of patients who are diabetic at the first day of diabetes. If you take them to do retina exam, you're going to get somewhere about 15–17% of retinopathy. So patient already have microvascular disease. And not only that, there's already quite a bit of significant increased risk of macrovascular disease. And really, it's just diabetes, which is kind of the ticking clock, which not only now they have increased risk of macrovascular disease, they have increased risk of micro. But again, I mean, the risk already exists prior to diabetes. And so we have to try to do whatever we can to see if we can delay the onset of diabetes, and also, you know, try to see if we can have any modification to improve the risk factor from the cardiovascular portion. Now, how do we diagnose pre-diabetes? So you have what we call impaired fasting glucose, you have impaired glucose tolerance, and you have compound glucose intolerance. So you, if you do glucose challenge test, for example, if the fasting glucose is you know, over 100 or so, then this is, you're going to call it impaired fasting glucose. If you're running post-challenge over the 140, then this is impaired glucose tolerance. And there are some patients who's going to have both abnormality, and of course, those will have more likelihood to progress to diabetes. And generally speaking, the patient who have impaired tolerance to the glucose challenge is more likely to become diabetic faster than those with higher fasting glucose. And if you have a patient who come with high fasting glucose, sometimes you also ask how long has it been awake before he came to do the blood test, and also about the quality of sleep. If patient have bad quality of sleep or sleep apnea, that's really affected. So we have to remember that fasting glucose is not very accurate sometimes in screening, so you are going to miss time diabetic. So if you have a high suspicion of somebody, you have to look at the glucose challenge test. Now you have to remember that this criteria look at the 2 hours glucose. I personally actually do 1 and 2 hours. And the reason why is early in the onset of the disease, you lose the first phase insulin secretion. And so, you know, you can be fooled with the 2 hours. And I can tell you, sometimes I see, for example, women with, you know, PCOS and their A1C 5.6, 5.7. But when you do the glucose challenge, the 2 hours could be 130, which looks normal supposedly, but the 1 hour will be, you know, 280. And so that's by far is not a normal response. And this person, I will be more aggressive with her. So at least for myself, at least I usually try to do 1–2 hours, the same glucose test we do for pregnancy, really. Now, when you come to hemoglobin A1C, what you can use as diagnosis for diabetes, you have to remember that even though we use a hemoglobin A1C of 6.5% as diabetes, but you still could be diabetic at 6.4 or 6.3. That the whole criteria of diabetes is you recheck and reconfirm the abnormality. So for example, let's say the A1C is 6.2 and you call him as pre-diabetes, but if you do the glucose challenge and the patient over 200 and you repeat it again, the patient is diabetic, even though the hemoglobin A1C is 6.2%. Now, what would make an A1C kind of marginally abnormal or pre-diabetes? So that's run from 5.7 to 6.4 for the ADA, and 5.5 to 6.4 to the ACE. And to be, you know, advocating, maybe you should look at the 5.5%, especially if you're very worried about the patient, especially if a patient, for example, female, and she told you I had a large baby last time, especially if she told you I have gestational diabetes before, or somebody who have strong family history of diabetes. So, you know, 5.7 is a little bit high to start screening. So even with 5.5, 5.6, you have to start thinking about checking people for diabetes, you know, and watch their progression, because they have to understand that they started this phase and they have to take it somewhat more serious. Otherwise, they're going to become diabetic very soon. So you want to delay the progression as much as you can. And so what's the risk factor? Well, I mean, I can tell you, I can fit multiple risk factors here. Risk factor is almost everyone. I mean, you're talking about somebody over 45, which is me. There is a degree of overweight. Our life is sedentary. There is a family history of diabetes. The HDL is low. I mean, you have everything. There is a fatty liver. So you have to look at all this as people who have a high risk of, you know, being diabetic and who need to be checked. And then, of course, people with sleep disorders, sleep apnea, shift worker, because those you really goof up mainly their physiological clock, and they are less likely to lose weight and more likely to gain weight, and they are going to be more insulin resistant. You're deranging their system. Of course, anybody who has poor quality of sleep, your cortisol level goes up, your stress level goes up. It's not a normal state. And so this is one of the reasons if people come with higher glucose, either if they are not diabetic or diabetic, you always have to ask about the quality of sleep. Then who is going to be checked? Well, again, you check all this overweight patient, people who have family history and first-degree relative, specific ethnic groups. There's history of cardiovascular disease, patient with low HDL, women with PCOS. And again, women with PCOS, it's advocated to mainly look at their lipid and OGTT, preferably every 2-3 years. People who are inactive, which is mainly almost everyone, and then those with A1C abnormal and so on. Now, how often do you check? Usually at least every 3 years. Now, again, that depends on the circumstances. I mean, if a patient, for example, had a BMI of 26 and his weight was 80, for example, and his fasting glucose was 99 last time you checked him, and a year later he already gained 8 kilograms. Well, 8 kilograms almost will quadruple his risk of diabetes. So this guy, I will check him. I'm not going to wait another 2 years to check him. I mean, so I mean, you know the patient, you know how they were, you look at their weight, you look at their lifestyle, and you take it from there. Anyway, why do we need to look at treatment of prediabetes? Well, that's in a big part related to their risk of progression to become diabetic. You know, and again, there's ethnic difference. Some people are more likely, for example, in the US, the Mexicans are the most likely, I mean, again, Hispanic to progress. But again, in that time of about 10 years, there is about 70% risk of progression of diabetes. And so that will be somewhere between 5 to 10% annually. Now you have to remember that patients, as we mentioned, who have the compound intolerance, which is the fasting and the after meal, actually they will have a higher rate of annual progression to diabetes, so 10 to 15% versus 5 to 10. Now, why would that matter for you? It matters for you because you will know the rate, and you know that this guy, I need even to be more aggressive, and you need to explain to them that, you know, if he only have impaired fasting, is less likely to progress than impaired glucose tolerance, and less likely to progress than if they have both. And so that's really important to kind of address with the patient when we're talking about. And the second thing we have to explain to the patient that actually you already have an increased risk of cardiovascular disease, comorbidity, retinopathy, nephropathy, and neuropathy. Now, that will sound a little bit unusual with the fact that there's a complication that we see with diabetes. But I can give you, for example, that there's some data to suggest that patient with retinopathy actually already can, or sorry, patient with glucose of abnormal, even if they run post-challenge glucose in the 150s, that already is associated with increased risk of retinal changes. So, you know, you don't have to have the 200 post-challenge. You can run 160s and you already start showing changes. Now, is everybody with sugar of 160 will get retinopathy? Of course not. So we have a genetic predisposition to become diabetic, and there's genetic predisposition to get complication from diabetes. And you're going to see some patients that have uncontrolled glucose and still they don't get complication as other people who doing a little bit better. So, I mean, genetic factor is very important. And so this is data from different resources, retinopathy, polyneuropathy, and nephropathy. One of them, the retinopathy related to the diabetes prevention program, again, pre-diabetes. And you can see that the odd ratio of retinopathy in the group that went into diabetes prevention program to have retinopathy, and those who progressed to diabetes were 12.6%, and those with pre-diabetic continued 7.9%. So there's already retinopathy there. Neuropathy is the same. There was a trial looking at glucose challenge tests and doing a kind of a questionnaire, a Michigan neuropathy scale. And again, you can see that those with impaired glucose tolerance and impaired fasting have a higher rate of having neuropathy. And then the same apply for nephropathy and having abnormal even creatinine. It doesn't mean it's from the diabetes, but it's pre-existing. So we have to keep that in our mind, and we have to screen patients at the time they were first diagnosed, because you are going to have patients already have retinopathy and nephropathy and neuropathy on day one of the diagnosis. And so the same time you see him as day one of diabetes, he already should know that he already have a higher risk of cardiovascular disease. And this is just a data of a combination of prospective trials that they were looking at the post-challenge glucose and association with cardiovascular mortality. And we know that from many trials like Helsinki data, Paris data, showing that there is much more correlation with the post-meal with the cardiovascular mortality and disease than the fasting. And if you think about it, it makes more sense, because we spend 14 to 16 hours of the day post-meal, and we have much less time overnight for the fasting part. So we're spending the majority of time, and this is the time where you have even dyslipidemia, or there's change and there's increase in triglyceride. And you know, if you check somebody with triglyceride of 140, let's say fasting, if you check it sometime after meal, it could be 800. And so, you know, these people have a higher risk of cardiovascular disease on top of the neuropathy, retinopathy, and nephropathy. So we have to be aggressive with them, almost as same as diabetic. Now, what about guidelines? Well, of course, the first important part is lifestyle. And you have to encourage to try to lose about 5 to 10% of body weight, and encourage to do at least 150 minutes per week. Now, this exact wording comes from the diabetes prevention program, because the intention of this program was to try to achieve weight loss mainly 7%. And at the end, they achieve somewhere in the north of 5%, and trying to do 30 minutes a day, 5 days a week. And so this did show a significant reduction on progression diabetes. We'll go over that later. For the ADA, again, same thing. They tell you 7% and 150 minutes. Now, there is multiple lifestyle modification trials, and again, diabetes prevention program mainly was looking at metformin as 850 BID versus lifestyle modification, mainly the 7% weight loss and the 150 minutes. And there was an arm of TCD before, but again, the efficacy of lifestyle modification was very effective, 58%, metformin was 31%. The diabetes prevention study from Finland, again, it's a smaller group of patients, but again, it showed that even with some modification of the lifestyle, it was not very intensive. There was a 39% reduction. The King study in China, again, lifestyle modification, patient had a lower BMI. Again, Chinese is a little bit different ethnically. The number of patients was not that big, but again, there was 50% reduction. So patient has to understand that they could have 30 kilogram overweight, but they don't necessarily need to lose 30 kilogram, number one, to reverse the course. And they may not be able to lose. You have to understand that the body may not let us lose all the excess weight we have. It's really hard battle as we lose weight. So patient has to understand that even if they achieve 5, 6, 7%, that by itself is going to reduce the risk of becoming diabetic 50%, which is a very nice odd. Of course, if they lose more, it's even better. The most important is patient do lifestyle modification. They have to understand that they need to exercise to maintain the weight loss, and that's where the problem. Patients do not exercise. They have to do moderate to high intensity exercise to be able to maintain the weight loss, and usually the majority don't do that and regain the weight. Now, we have other agents we can use to help in protecting or preventing the progression to diabetes. There's multiple trials, including metformin in the diabetes prevention program, acarbose and stop NIDDM, Actose, and Avandia, again, in the ACT NOW study. And all of them showed reduction in progression because of the safety and the efficacy of metformin. And I'll go later over the data. Metformin tend to be the most preferred and indicated treatment for prediabetes, and especially in those with BMI 35 or more, age below 60, and women with gestational diabetes. And again, you're going to say, why is that? I'll show you later. Now, what's about guidelines? Mainly is exactly the same. So BMI, weight, age below 60, and gestational diabetes. And so if you look at it from perspective of guidelines, you have patient, they have prediabetes, you do the lifestyle modification, you push them as much as they allow you to do that. Again, at the end of the way, when you put a kind of a way of eating, you cannot make them do what you think it's correct, because they may not do it. You have to kind of arrive to some kind of a happy medium for them that they agree on. And then you look at adding the metformin, and then you need to recheck them almost every 6 months and do possibly their glucose challenge to see how their numbers looks like. Now, of course, let's say you put patient on metformin, they were working on their diet, and you do the OGTT, for example, and the A1C, and let's say the A1C after the metformin was 5.8. So the question is, how do you know the patient is doing better? Because patient will tell you, I want to stop the metformin, and typically I advise them, of course, not to do it. Most likely this is lifelong. Number two, you will know that the patient doing better, because if they maintain the same treatment and they're doing well and losing weight and exercise, you're going to see that the A1C start to trend down. You're going to see that the glucose trending down. You look at the trend to see how that's changing. And so then we go back to diabetes prevention program. Mainly, it went from 1996 to 2001. And again, I'll go over the data. And then there's, 80%, about 84% of the patient agreed to have a follow-up just to see how they're doing. The group who was taking metformin continued to take metformin. And when you look at the data, you can see that, again, as we mentioned before, that there's 31% reduction in progression to diabetes with metformin, intensive lifestyle, 58%. But you have to remember, people don't follow very much on the lifestyle, and I'll show you that later. And so if you look at the group of patients, you can see that those with higher BMI have 51% reduction in progression of diabetes with metformin, similar to the lifestyle. And again, this is again show you why the recommendation was to to advocate using metformin in diabetes prevention on those with prediabetes with BMI 35 or more, age below 60, gestational diabetes, because even when you do the subgroup analysis based on the age and the gestational, you get the same data. Now, what's about if you follow patient and you see over 15 years, then you're going to see that metformin will continue to have very nice reduction in progression of diabetes, not as initially the trial, but they continued this for up to 15 years follow-up. And the other nice part about it, that even though the group who did the lifestyle modification initially lost more weight, but you can see on the follow-up that actually metformin was able to maintain to a certain degree the weight, whereas the lifestyle went up and their weight back. So that shows you that metformin will have an effect in helping not regaining the weight, not necessarily to lose weight. I mean, the average weight loss is about, in the completers of metformin, is about 2.2% weight. But it not only necessarily will help you only lose 2%, but it will help you not regain more, which is also an important factor. And again, I'm not advocating metformin as weight loss. Now, what's about the fasting glucose? Now you can see here the lifestyle intervention in dark blue, metformin in pink. And so you can see that even though initially group with lifestyle modification had a better fasting, but you can see that the cross line, and now metformin showing better fasting glucose. So there is efficacy if you continue to use metformin, and that's an important fact to show the need to continue to treat patient. And then when they become diabetic, then you go and take it from there. Now, the other thing, there's another trial, it's called the Indian Diabetes Prevention Program. And again, it's a smaller trial, look at control, metformin, lifestyle, or combination. And you can see that actually metformin by itself, lifestyle by itself, and the combination did almost the same. There was no one arm superior to the other. So, it doesn't mean that you tell patient based on this 500 patient trial, don't exercise and don't walk and don't watch your food. But, it has to give you an idea of impression of how beneficial the metformin is. Now, one other thing is if you look at people who had impaired glucose tolerance, what the chance that I can convert them to be normal. And so this is a smaller trial, again, in 70 patients, but they use different treatment, which is 250 milligrams 3 times daily, but there was 85% conversion to this. Now, when you go to diabetes, again, I'm sure you've seen this slide 500 times, but we remember that now in the at least per the guidelines, that patient with established disease, you have to consider using the SGLT2 and GLP-1. Of course, SGLT2 more if there's a renal disease, heart failure, proteinuria, and GLP-1 more of atherosclerotic patients. And this is after metformin, and you'll start those patients on this treatment irrespectively of the baseline A1C. And we always have to remember that we have to focus, even before diabetes, on the lifestyle modification. You even can proceed and look at weight loss medication. There's multiple agents available now to try to help your patient, at least to give them the startup, and so they can continue on their exercise program. And then you go to the other treatment. If you look at the ACE, American Association of Clinical Endocrinologists algorithm, it's somewhat similar. It's but again, put it very clearly on the lifestyle modification, and they said that's independent of glycemic control. Again, you have to consider again SGLT, GLP-1 in patient with established disease, but also you can see that their target for hemoglobin A1C is lower than the ADA, so 6.5% in the non-complex patient. And so they advocate combination therapy with an A1C of 7.5% or more. Now, so when you look, you start with metformin monotherapy, as long as the A1C below 1.5 above individual at target. So again, every patient has a different target. The ACE will tell you you do monotherapy A1C 7.5, you do combination. If for the ADA, if the baseline hemoglobin A1C is more than 1.5. So let's say your target 7. If you're over 8.5, then you go right away to combination, because in this case, one agent is not going to be enough, not metformin or not any other agent. Again, for ACE is a little bit more aggressive on that. And I'm going to move a little bit fast just because of the time. Now, is metformin effective? Yes. And this is just going over different efficacy. Now, again, you have to remember this is a different data, not necessarily head-to-head data. But typically, for example, with metformin with baseline A1C of 9, usually you're going to get about 1.5% of A1C reduction, just to give you an idea. And of course, there's a reduction in the fasting glucose, there's a reduction in the A1C, and the reduction is dose dependent. So as you increase the dose from 500 to 1,000 to 1,500 to 2,000, you're getting further reduction in the A1C. Now, do we have data to support the cardiovascular protection? The answer is yes. This is the UKPDS and the follow-up trial. And the follow-up trial showed very clearly that there's a legacy effect. Then despite the fact that patient discontinued their treatment and they weren't on their own, they continue to show a reduction in all-cause mortality, myocardial infarction. You have to remember this is the whole cohort. So for example, there was a reduction 33% myocardial infarction, but in the group taking SU was 15%. In the group taking the glucophage is higher. And then also the all-cause mortality here, 27% for the metformin, and I think it was 15% for the group was taking SU on the intensive group. So you have to look at the drug, you have to look at the guidelines, you have to look at what you know. Again, it's been for many, many, many years before I was born. And again, we know the side effect from perspective of GI, the possible B12 deficiency. Really, there's no much risk of hypoglycemia. You have to compare to the other agent, including the hypoglycemia, the insulin, the weight gain, the hypos, the TZD, the weight gain, the fluid retention, GLP-1. But at the end, I don't think this is a fair comparison, because at the end of the day, you are going to be very likely over time using combination therapy. So you always start with metformin, but then you're going to add things to it, usually as needed. And so now with having extended release, again, you're able to have it in a polymer matrix, which then delay the absorption and try to help maintain the exposure of metformin, so you can take it once daily. Now, of course, by doing it once daily, you're going to improve the adherence, and the more adherent you are, the better your A1C. And so usually every 10% improvement in adherence, there's a 0.1% reduction in A1C. Now, again, when you use the extended release form, you're going to have less GI effect and less diarrhea. That's the reason really why patient will choose to change to XR. Again, here in DHA, we only have XR now, and we have the 500 milligram fast acting. How do you switch? Well, again, I'll go to this one. So if a patient taking 500 twice daily, you go to 1,000. If they're taking 850 twice daily, they go to 2 of the 750 extended release. And if they're taking 2,000, they go to 2,000. And if they're taking 1,500, they go to 2,000 of extended release. This is just a general ID, or they can go to 2 of the 750 and XR. So at the end of the day, you have to remember metformin is a strong drug, safe drug, has been many years. It's been on mainly every single guidelines as the first drug to use in the treatment. We have data on prediabetes prevention. It is important to treat prediabetic, and we have very strong data on diabetic. Of course, having GI side effect being the major side effect, having extended release will reduce this and improve compliance. You want patient to be on metformin, and I see a lot of patients. For an example, I seen a patient on Thursday and she's taking just metformin, just insulin, and she continued to gain weight. And, I was like, why are you not taking, for example, metformin or glucophage? And she said, well, once I stop insulin, they stop the glucophage. I would not do that, because what you see very clearly that people will continue to need more and more insulin, and they continue to gain more and more weight. So it is advisable that actually patient will continue taking some of the oral agent, at least, to try to help in avoiding or negating the negative effect of, for example, metformin. Now, I'm going to go over the questions that they were sent to me. I'm sorry I went a little bit too fast, and I'm sorry about the technical part. So regarding prediabetes, should it pharmaceutically or lifestyle modification? Again, I mean, if you're lucky to have somebody who follow lifestyle modification, go ahead. Most patients, sometimes they tell you they don't want to do that. They don't want to do lifestyle modification, or they say, give me a chance to try it. You give them the time, but you have to put a timetable. Say, okay, you have 3 months, 6 months to try, and if you're not on target, we'll move on. What's the best option for newly diagnosed diabetic patient, metformin or glucoside? Of course, newly diagnosed, it has to be metformin, not necessarily glucoside. I mean, that's standard. Plus to it, you don't have risk of weight gain. You don't have any risk of hypoglycemia. Pre-diabetic patient, again, if you're going to follow the study, which is the diabetes prevention program, it was 850 BID. And so sometimes I see, patient given 250, or they tell them take 500 milligram pill and take half of it. Most likely is not going to do much. So you preferably want to follow how the trial was done, which is the 850 twice daily. If there is difference in the beneficial effect, not really. But again, you are going to be more aggressive in the people with impaired glucose challenge, because those are more likely to progress to diabetes. And the last question was, do you recommend metformin for pediatric patient with prediabetes? Now, I don't treat pediatric. Again, it's very safe drug. I mean, I work in the private, do I have some people who have, for example, PCOS and prediabetes? Then I tend to use the metformin in that group. But again, I don't deal with pediatric, generally speaking. And that will finish my part. Thank you.
So I will start. If Dr. Amir will allow me to introduce the first speaker, Dr. Iba. I think many of us know Dr. Iba. She's the Dr. Iba Al-Uzairi. She's the chief medical officer at Desman Diabetes Institute, and she finished her study in Dundee University, UK, and also she got the Fulbright fellowship in Diabetes Institute is affiliated with Harvard University Medical School. So I mean, I know one interested it's a long CV. That's why I got it from Iba. So Iba, I think she will go on to talk about the education, structured education, actually in type 1 and the hypoglycemia. So just join me to welcome Dr. Iba, and Dr. Iba, the floor is yours now. You can start your presentation.
Thank you, Dr. Abdullah and the organizing committee. It's a pleasure to be with you here. I'm privileged to be asked to give this presentation. I would have loved to be with you all face to face, but I think this is the best we can do, and at least to continue our education. I'm trying to share my screen with you. So that's me again, and that's the Dasman Diabetes Institute. So I know you're all well aware of the DCCT trial, and with the DCCT, we knew that if you have the intensive control, then you have a better control of the complication, but that was as the consequences of the hypoglycemia. And in our main talk here, we really want to see how we can, what are the main aspects that's influencing hypoglycemia? So is it the better medication today that we have with the modern insulins? Is it the new technology, or is it my passion into education? And what are the psychological factors that we always have to bear into account when you're looking into hypoglycemia? I think Dr. Reem has summarized this really well. We have a lot of advances today with our insulins, but as you see, that's the difference between the glargine and the NPH in type 1 diabetes, and there was really no differences in the A1C or in the hypoglycemic events. Even when we look at digludec versus the glargine, again, you see a slight difference in the fasting plasma glucose, but there is no difference in the overall hypoglycemia, very little effect on the nocturnal hypoglycemia. So just to summarize things for you, do not improve the A1C or reduce the overall hypoglycemia. Yes, few individuals will benefit from the nocturnal hypoglycemia. And many of us think when we look at severe hypoglycemia, we think those who are more tightly controlled are those people who are at risk of hypoglycemia. And this is not true. Looking at the study with 11,000 individuals with type 1 diabetes across all ages from 6 years up to 50 years. And if you look down the A1C gradients, you see from A1C 7 to A1C 9%, the hypoglycemia is almost very similar and might even go higher with the higher A1C, something that we always think we have to concentrate more on the tightly controlled. What is evident is the hypoglycemia really increases with the age. So you can see how it goes into horizontally. So why doesn't the traditional approach of type 1 diabetes work? So many of us say we refer our patients to educators, we give them, refer them to the dietitians. I think majority of what we're doing, because treatment starts with an insulin dose and the rest of the treatment fits around this. And the doctors and nurses are in charge and they're adjusting most of the insulin at clinic visits. And we have developed this and we have transferred it from the acute care model. So we've never shifted really to an outpatient care model. So let's pause on the pioneers of the flexible intensive insulin therapy back in the 1923, Jocelyn and Elliot and Philippe Assal. And Late Berger and his wife really has made the huge difference into the therapeutic education, the diabetes teaching training program, DTTP. When you see at the DTTP, and that was an inpatient initially, you see the difference in educations where we moved from the red circle to the green triangle, and we have more than 50% reduction in the severe hypoglycemia after attending the training of the education. This has moved and transferred to the UK, where people were intrigued what was made difference in the Germany and how we can adopt this more. So they developed this more into the DAPHNE program, and that is the structured education type 1 diabetes program that has today more than 52,000 graduates from the UK, and it has more than 80 publications. The DAPHNE graduates are in many different parts of the world, so it did not only work in the UK, it's in Australia, Ireland, New Zealand, Kuwait, and Singapore. So how what is it different and what is the magic about the Daphne program? It's a structured education program with a lot of quality assurance. There is a dedicated curriculum, and also there is internal quality assurance, external quality assurance, collaborative group, and it much fits into your cultural needs. It's all about adult education theory, so it's a hands-on experience. So there is nothing over PowerPoint or over lectures. It is all actually living together the experience. So we live together for more than 25 hours with the participants eating out, doing the exercise, carb counting our local foods, and they come up with a lot of their own sharing, their own glucose within the group. So all the answers comes within the group structured education program. Looking at the Daphne outcomes, you see that there's 50% reduction in severe hypoglycemia and 43% had the restoration of their hypo-awareness. And when you look at the real world data, across all the collaborative centers, you can see the prevalence of the severe hypoglycemia at baseline and after 12 months, that even greater than the 50% reduction. And in addition to this, you have the restoration of the awareness that is persisting after the Daphne count. This is our results also in Kuwait. You see the hypoglycemia in the second bar chart, and you see the major reduction in the severe hypoglycemia. When we're looking at our own results, this is a very high costly effective program where we had 60 paramedic calls prior to the course, ended up in 3 paramedic calls, and the 105 severe incidents of hypoglycemia leading to 2 severe hypoglycemia. What we've done even further, we have developed the Daphne Ramadan curriculum into this, and we have published our results to show that your Ramadan fasting even lowers your hypoglycemia risk, and you are at a lower risk of hypoglycemia. We manage the glycemia and the insulin dosages completely different to what the IDF recommendations, and that's developed on the Daphne Kuwait program. We have even further done a qualitative work on the Ramadan workshop and their hypoglycemia effect and have seen the dramatic effect. So what we're really trying to do is shift our thinking. So if you see at this slide, many of you might see this as a 4 rods, while others might see it as a 3 rods. What we need to change is we all say, oh, we do have an education program. We send them to our educators and dietitians. We need to teach the people in one-to-one. If you use the same old thinking, you're going to get the same old results. And the way that I look at it, this is a life course, skill training, and that's what we need to change the people and change their thinking. Other courses have really embedded into the Daphne even further into those who have hypo awareness. So we have the BGAT training, that's a blood glucose awareness training, which is 8-week psychological training program focused on the internal cues. You have a trained psychologist, and that leads to 92% reduction in severe hypoglycemia. We've taken this and embedded it into the Daphne Heart program, and that is a 6 weeks interventional using motivational interviewing in those people who have the impaired awareness hypoglycemia, and you can see the magnificent effect of the reduction in the severe hypoglycemia and in the moderate hypoglycemia in your GOLD score and Clark score are all the scores that are related to the hypoglycemia. Comparing Daphne account with technology, this was published in BMJ, a cluster randomized effect looking at MDI versus pumps. And what we have seen that there was no difference at all in the severe hypoglycemia between people who have received Daphne and MDI versus Daphne and the pump. So it gives you the notion that everything is in the back in education. Looking more into technology and the effect of the hypoglycemia and looking at using technology, blood glucose monitoring, hippocampus study, and again, whether it's hippocampus study or the in control study, you're looking at different technology, and you see across all of them there was no change in the impaired awareness hypoglycemia. So the only thing that made the difference was the education. This is a newly study that's published in 2020, looking even within our pediatric groups, and you see that the reduction of the DKA after CGM initiation in the pediatric group, and if you look at severe hypoglycemia again, 6 months onwards, there is no difference whatsoever in using your technology.
looking at the new technology of the 670, hybrid closed loop, again, newly published in 2020, and you'll see many people start, not using the new technology after a while because of the reasons of calibrations, number of alarms, and too many things needed. Again, it did not show the difference when it comes to the severe hypoglycemia. Dr. Reen has shown you this, that the impaired awareness hypoglycemia increases your risk of severe hypoglycemia, and today no technology has demonstrated a significant and sustained improvement in hypoglycemia awareness. So the only thing that produces long-lasting effect is the structured education that has been benefited by the DAFNE program proven and by the DTTP and by the BGAT training. Whenever we see hypoglycemia in your patients, you always need to assess, you educate, and you discuss and decide, and then prescribe the best, how you're gonna deal with the account. Many of us, we know about the glucagon, and now we're trying to shift from this, and we're lucky today that we have the nasal glucagon that, takes much better and much faster than your intramuscular. It takes 16 seconds. If we instructed the caregivers, we have done this in the simulation lab, whether it's or the non-instructed acquaintances, and it takes 2 minutes. So you'll see the 16 seconds versus the 2 minutes. And today we're so lucky that is already available in the US. That's the first, auto-injector for severe hypoglycemia that is available today. So there's no more mixing or having the difficulty in this. And this is now available in US, coming very soon to our region as well. So what I would like to really show you, this is the meta-analysis showing you today, education has the efficacy of 60% reduction in severe hypoglycemia across many of the meta-analysis showing DAFNE Heart, what I showed you, HIPOS, DTTP, and the BGAT study. So I hope that I've really tried to convince you today that the structured education plays a pivotal role in reducing the risk of hypoglycemia. And what I want you all to stop here, and what I find really intriguing and heartbreaking, that when it comes to diabetes and education and insulin therapy, when will we ever learn? It appears very strange to me that the diabetes education is not obligatory. It's made optional, it is unstructured, and easily abandoned by the excuse of lack of time or money. Think of it, if diabetes is the analogy of cancer, how many people will tell you, I do not have time to go to my chemotherapy and it's optional to me to go this week or the next week? That's what we need to do, shift our mind, shift our way of thinking to the new thinking. I believe in Churchill when it says, it's no use saying we are doing our best, have got to succeed in doing what is necessary. It is not enough to say we have the educators, we're using the dietitians, we're using the rest. It is the time that we shift our movement to really structured education that has the evidence-based medicine. And with this, I would like to conclude and thank my team, the great team in Dasman Institute that is looking after the DAFNE, all the DAFNE graduates and the DAFNE UK and the Central DAFNE, and all of you. Thank you all. This is our email, and we would be more likely happy to see you all face to face. Visit us in Dasman so you can see DAFNE live, and we hope to make this the collaboration even more to help our patients and to move on from the very expensive what we're using tools today to go back to our nature and saying education, education. Thank you all for listening. And without the education, we would not be all today in the platform using our education to get together. Miss you all, and I wish to see you face to face sometime. Thank you all.
Thank you, Dr. Riba. It was very, very nice presentation. I have to invite you to my country in order to talk to our MOH. It was really nice presentation. Thank you so much. Thank you so much.
Thank you. Thank you for the invitation, and thank you for all of you.
Don't worry about it.
Thank you.
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum, everybody all around the world. I would like to start by thanking the organizers for the invitation and giving me the chance to speak to you tonight. So I was given the topic on insulin choice and how that impacts hypoglycemia in patients with type 1 diabetes. These are my disclosures. And let me just start by saying, so patients with type 1 diabetes, as you all know, are dependent on insulin, and therefore iatrogenic hypoglycemia is a fact of life in these patients, with an average of about 2 episodes a week, as shown in many studies, with one disabling severe attack a year. It's been shown in some CGM studies that time spent with a blood sugar below 70 in these patients can reach up to 6.3% or 1.5 hours a day. Now, one of the issues that we've always had leading to a lot of heterogeneity between studies in reporting of hypoglycemia is that the definition was very different between trials, and it took us quite a long time to agree on one definition that has lately been adopted by many of the societies, which levels hypoglycemia into 3 levels. Level 1 being the alert value once the blood sugar goes below 70. Level 2, the serious biochemical value when it's less than 55, which could be severe or not severe. So it's not severe if it's associated with symptoms and the patient can take care of it, and severe if it's associated with impaired cognitive function and they need external help. And for patients without diabetes, usually we have a very strong protective mechanism that takes place once the blood sugar is below 4.6. So once they're 4.6, we have an inhibition of endogenous insulin secretion. And once they reach levels of 3.8, the counter-regulatory hormones, glucagon and epinephrine, start acting to revert the blood sugar back to normal. However, these 2 mechanisms are not available for patients with type 1 diabetes, and as it is an exogenous insulin-related hypoglycemia, and they tend to be dependent on having the symptoms so that they could take action to recover from it. However, with more time spent with asymptomatic episodes and with time, they tend to lose this protection even from the symptoms, and they might end up having severe attacks with loss of cognitive dysfunction and cardiac and neurologic complications. So this has been recognized quite some time ago, from the beginning of the introduction of insulin into practice. And it was shown that with the recurrence of these attacks, patients tend to lose the symptoms, and this may lead into dangerous severe hypoglycemic episodes. And in those who do lose the awareness, the incidence of having severe hypoglycemic episodes is 6-fold increase in patients with type 1 diabetes. So generally speaking, many of the hypoglycemic episodes are reversible and treatable, but we have to keep in mind that it is not benign. It can be fatal. It has been associated with death and what is called bed syndrome. It's been associated with cardiac arrhythmias, ischemias, and other cerebrovascular complications. So it is extremely important that as part of managing these patients, we try our best to prevent hypoglycemia. And when it comes to insulin choice, from the very beginning, it has been noticed that insulin batches differ in potency and that recurrent hypoglycemia is common. And the quest has taken us really many years, and we have developed, as of now, a lot of new insulins that and we have tried to, as much as we can, replicate physiology. However, this still is, a quest ongoing. And with all these developments, and if you look into most of the studies that have been done in patients with type 1 diabetes, it doesn't seem that we have managed to reduce the frequency of severe hypoglycemia. So let's talk about these insulin choices and what does the evidence tell us and how do they compare. So in general, we'll be talking about long-acting insulins and short-acting insulins and going through the literature as it relates to type 1 diabetes. So starting with long-acting insulins or basal insulins, now the new basal insulins, whether first generation or second generation, have managed to improve a lot in terms of duration of action and less variability. But how do they really compare when it comes to clinical outcomes? So let's go all the way back to comparing the most used insulin basal, which is the glargine 100 and detamir, versus our old NPH. Overall, the amount of studies done comparing these two agents are really tremendous. And overall, you could see that for the most part, they have shown that when it comes to efficacy, they seem to be very comparable, with some studies showing that maybe glargine 100 is better in regards to A1C reduction and in regards to better fasting blood glucose. But when it comes to hypoglycemia, doesn't seem to be that they're much different in regards to general hypoglycemia, with some evidence pointing towards that maybe glargine 100 has lower hypoglycemia, nocturnal hypoglycemia specifically. But glargine 100 does have the patient satisfaction and the better patient compliance, and it has been also shown in some studies to be associated with less weight gain compared to MPH. Detamir doesn't differ that much in comparison to MPH in regards to, again, similar efficacy, some trend towards less hypoglycemia and nocturnal hypoglycemia and less weight gain. And when they are compared towards each other, it doesn't seem that they differ that much in regards to hypoglycemia or efficacy. So in this meta-analysis published in 2018, they looked into 28 clinical trials that compared the long-acting analogs versus MPH. Overall, about 8,000 plus patients, of which 4,600 were on analogs versus 3,557 on NPH. And looking at these, the main clinical outcomes, it seemed that there was a tendency towards more significant A1C lowering in the longer acting analogs, with some statistically significant but not much clinically significant overall general hypoglycemia benefit, not much in regards to severe hypoglycemia, but there was significant reduction in nocturnal hypoglycemia. So taking it all together, it seems when it comes to the first generation analogs, glargine 100 or detamir versus MPH, they do seem to have a modest benefit compared to MPH in regards to hypoglycemia, but when they are compared towards each other, they seem to be very comparable and similar. So moving on to the second generation analogs, the new analogs, glargine 300, Toujeo, or the Digludec, how do they compare to the first generation analogs? And did they really make a big difference? So the new basal insulins have a much different structure. Digludec depending on multihexamers that form in depot and then are released into monomers, and this gives it a more longer duration of action, versus glargine 300, which is the same as glargine 100 depending on microprecipitations that don't dissolve in normal pH, but it's a little bit up concentrated. And again, this gives it a little bit more longer duration and a little bit more flexibility in the way that it can be taken. However, in clinical trials, in randomized trials, the edition 4 trial specifically that compared glargine 300 versus 100 in patients with type 1 diabetes, again, did not show that it had that much difference in regards to efficacy, whether looking at hemoglobin A1C or fasting blood sugars. And when they looked into hypoglycemia, so there was a little bit of trend towards maybe less nocturnal hypoglycemia in the first 8 weeks, but this did not carry on when they looked overall the whole duration of the study of 6 months, and there wasn't much difference in general hypoglycemia. And with the follow-up study of this same trial after 12 months or 1 year, again, there was not much difference between the two in regards to nocturnal or general hypoglycemia. This was followed by some real-world evidence from the UK multi-center retrospective study that compared patients who were put on glargine 300 6 months before versus 6 months after. So what they found was basically 6 out of the 298 patients had some episode of severe hypoglycemia before versus 4 after. So the numbers were really small, and it's difficult to, make a lot out of it, but maybe there's a trend there. So overall, glargine 300 versus glargine 100, similar efficacy, maybe less hypoglycemia, specifically nocturnal hypoglycemia, and maybe less weight gain that was showed in one study but not the other. So what about digludec? How does it compare to glargine 100 when it comes to type 1 diabetes? In Switch 1 trial, it was a crossover design. And what again, they found no much difference in regards to A1C, but they did find some significant lowering in hypoglycemia rates compared to glargine 100. And again, this was consistently shown in real-world data that came out later in patients with type 1 diabetes. So if we would like to overall compare the glargine 300 or the digludec or the second generation in general compared to the first generation, there might be some modest benefits in regards to hypoglycemia. However, more studies still are needed in that. How do they compare towards each other? Some pharmacokinetic studies have showed conflicting results in regard to which one has more valuability than the other, but currently we don't have any head-to-head trials specifically in patients with type 1 diabetes comparing the two agents. So I guess as of now, we could fairly say that they're probably comparable. So let's move on to short-acting insulins and how that choice affects the risks of hypoglycemia. So comparing the first generation rapid-acting analogs, whether Aspart, Lispro, or Glulisine, compared to good old regular insulin. Again, there's many trials out there, some of which have showed that they have better efficacy, others did not. Some have shown less hypoglycemia, others showed similar hypoglycemia, but the majority probably would agree that the postprandial 1 or 2 hour postprandial sugars were better. And in this Cochrane review that was released in 2016, they did find less numerically severe hypoglycemic episodes in patients taking short-acting compared to regular, but because of the heterogeneity of the data included, the evidence was graded as very low. And there was a little bit of benefit of A1C lowering. However, it didn't seem that it was that much clinically relevant. And this again shows the overall odds ratio of 0.89. However, it does cross one, so statistically not significant. This is in regards to severe hypoglycemic episodes. So again, when it comes to hypoglycemia, it's questionable, but maybe there is a slight benefit of using rapid analogs compared to regular insulin. How do they compare to each other? Overall, most studies have shown that they have very similar efficacy, no difference in hypoglycemia, and because of the easiness of the use of the pen, the adherence was much better compared to regular insulin before. So moving on to the most, the new type of insulin, which are the faster acting, so faster acting aspart. And here we have slightly approached, or we're trying to approach more physiological profile. So you could see in blue, this is the normal pancreatic secretion of post-meal, and this is where we were with regular. So with fast-acting analogs, we came a bit closer, and with the ultra-fast, we're even more close. But has this affected clinical outcomes? So let's look into the data. The 3 available agents that are ultra fast right now are the faster aspart, ultra rapid Lispro, and the bichaperone Lispro. The one with a phase 3 published clinical data is faster aspart. For ultra rapid Lispro, they're still in abstract form, and for the bichaperone Lispro, we still don't have much data. And basically, these 3 agents have different mechanisms of action for increase. So they either depend on increased subcutaneous blood flow, like with faster aspart, or through enhanced diffusion or vascular permeability, like with the ultra-rapid Lispro. And as a summary of all phase 3 trials for faster aspart versus aspart, we find that a little bit benefit in regards to A1C statistically, but doesn't really seem to be that much clinically relevant. Better 1 hour postprandial control, but overall hypoglycemia did not seem to be that much different from regular aspart. So overall, I think we could, to summarize, when it comes to basal insulins, maybe first generation could be preferred over NPH, second generation over first, and it seems that within the first and the second generations, they seem to be equal. For prandial, I don't think the evidence for fast aspart is that strong yet, so probably we still are sticking with our first generation analogs, the Lispro, aspart, and glutathione. And this has been recommended in a recent review where they considered, based on available evidence, that for choosing basal, your first choice probably would be one of the second generations, or the Glargine 300 or Digludec. Second choice would be the first generation, like the Tamiro Glargine 100, and third choice would be NPH, depending, of course, on your availability and what you have in your country. And for the prandials, the first choice, depending on flexibility and convenience, Lispro, aspart, glutathione. And then, if available, faster acting aspart, and the third choice would be regular insulin. However, we have to remember that hypoglycemia has more to do with the excess insulin, and it's more important that we think about how to avoid that, and through proper decision making and adequate insulin dosing, matching both food and exercise, and maybe within the future finding some sort, I mean, there's a lot of potential for glucose sensitive insulins, because that is what matters, and that's probably because regardless of the type of insulin at the end, the insulin receptor is the same, and the excess insulin on board is the main reason for the hypoglycemias. And more important in my mind than the insulin choice itself is the proper training. And we're going to have a whole talk about that. And it's not a new concept. It's been there since the 80s and 90s, and it has proven without doubt that it is what makes a huge difference in reducing hypoglycemia incidence in these patients. Now, technology, again, of course, and having closed loop systems and sensing hypoglycemia and alarms have also showed a great difference. And when it comes to patients who are MDI, probably there's a lot of hope with the connected pens to CGM. However, still more research and more studies are needed on that. So overall, approaches to reducing hypoglycemia in clinical practice in patients with type 1 are not solely dependent on the choice of insulin. It's just one of the elements of reducing insulin excess, but more is, importantly, we need more training in self-management and blood glucose awareness, the proper use of technology, alerting and how to alert patients for hypoglycemia, restoring symptoms of awareness in those who have unawareness, and maybe there is some role for augmenting the counter-regulation in some of patients who need it. So in conclusion, I think I've shown you that rates of hypoglycemia have not much fallen despite all the advances that we have in technology and the types of insulin available. The current insulin replacement regimens remain far from perfect and far from what normal physiology is. However, with what we have, it seems that with analogs, they do allow greater flexibility, and they do have modest benefits in reducing hypoglycemia and weight gain, and maybe better efficacy. The second generations provide better variability, but have not clinically shown that much difference, but do have a slight benefit in regards to hypoglycemia, and maybe kind of be recommended in patients who have underlying increased risk to start with. Flexible insulin dosing training remains the cornerstone in preventing hypoglycemia in all patients with type 1 who are on MDI, and the ideal solution probably requires some sort of the insulin delivery that is sensitive to blood glucose to eliminate the necessity for decision-making by patients and excess insulin on board. And until that happens, we're all staying tuned. And with that, thank you very much.
Thank you, Dr. Reem, for a nice presentation. The organizer told me because of lack of time, we have moved to the next speaker, and we don't have any time for Q&A. We can keep it for the end of the session.
As always. Okay, Dr. Amir, can you introduce Dr. Walid? So I have already, so please.
Okay. Thank you to accept the invitation and have your nice presentation, I'm sure, about the glucose monitoring, how and why. It's a very nice topic. Dr. Kaplan is the consultant pediatric endocrinologist. He's the chairman of the pediatrics at the Taban Hospital, UAE, and he has published many articles on diabetes, especially diabetes and Ramazan, growth disorders, and calcium and bone mineralization disorders. You can see many things about his awards and about his research on the topic of the presentation. Thank you. You can continue to play. The stage is yours, Dr. Wali.
Thank you very much. Thanks for the invitation and thank you for the introduction. I hope my computer will not cause me a surprise because my screen turned black twice during the presentation. So I'm going to do my best to keep it alert for the presentation and try to keep the time. So my objective is to cover the historical evolution of blood glucose monitoring and then summarize the blood glucose requirement in type 1 diabetes according to the ADA and SPAD, and then cover the continuous glucose monitoring in terms of advantages and current guidelines. If we look through the history of blood glucose monitoring, the first glucometer was made in 1970. So this is only a 50 years industry. It is really recent compared to many other things we have nowadays. Anyway, the first meter was nothing like the meters we know today. It weighed 1.2 kilograms, cost $500, which is equivalent to multiple $1,000s nowadays. It wasn't meant for home use, but for hospitals and clinics. And about 10 to 15 years later, glucometers became available for home use. They became smaller, but yet still relatively very bulky comparing to the meters today. They were still need calibration, cleaning of blood products, and they were not very fast and as nice as the ones we see nowadays. And in the late, maybe mid to late 1990s, the meters became smaller, faster, requiring less blood, and the strips no longer needed coding with every new bag. And then the results were fast. In 1999 was the first blinded continuous glucose monitor. It was used mainly for research purposes. And about 5 years later, the real-time continuous glucose monitor became available. At that time, patients became able of seeing the changes in their blood glucose or in their glucose, not necessarily blood, and then taking the proper action before they run into complications. And then in the 2016, we had the most recent addition, which is the intermittent scanning continuous glucose monitor. According to the ADA and the SPAD, any patient with type 1 diabetes who's using insulin on a multiple daily injection need to do 6 to 10 blood glucose monitoring per day as a minimum. And I have listed the events where those testings should be done. There is very strong evidence that shows the positive correlation between the number of blood glucose testing and the HbA1c, both in adult patients as well as in pediatric patients, as shown from the type 1 diabetes database. And this is true for all age group, and it is true for patients on insulin pump or patients who are on multiple daily injections. So the more blood glucose testing, the lower the HbA1c. In response to that, the glucometers today have a very common features of being small in size, requiring small amount of blood. They're more accurate and meeting the new ISO accuracy requirements. They give rapid results within 5 seconds. They have large memory for hundreds of numbers, and all of them have software that shows summary and breakdown of the readings. In addition to these general features, some meters have specific features such as measuring serum ketone, giving color-coded readings for patients who might not remember what the target numbers are, and then some meters help in those calculations as well. Now, in spite of all these changes, the patients are still not doing the minimum of blood glucose testing. This is from the type 1 diabetes exchange registry. And for more than 20,000 patients, they have screened across all age groups, as you can see on the top. The average blood glucose testing is 5.5 per day. The lowest two groups are the adolescents group and the young adults group, and they're doing 5.2, 4.4 readings per day, which is less than the minimum of 6 readings per day as required by the ADA and the SPAD. The Children's with Diabetes Organization showed that between 1998 and 2007, almost 10 years period, there was nice incline in the number of testing, but then for the following 10 to 13 years, the number has been about 7 readings per day, which is, even though meeting the requirement of 6 to 10, in practice life, it is not going to be enough to make the insulin dose adjustment or recognize or the events of severe glucose changes. Recent study done in Sweden, and the reason why we chose Sweden, because they provide meters and strip free of charge to all patients, so there is no financial burden. And in this study, they have looked at 138 patients with type 1 diabetes, and as you can see from the figure, less than 25% of those patients are testing more than 6 times per day. So there are limitations for the blood glucose monitoring despite of the changes or improvement in the meters. It is still relatively time-consuming process, especially if it's going to be done multiple times a day. It doesn't show the trend of glucose going up or going down, rather than it shows a screenshot of the current reading. There are no alarm features that alert the patients to the changes. So if they do the testing, they know what their numbers are, but if they don't do it, those numbers will go unnoticed. There are no synchronization with insulin pump, which will be very much needed for the closed loop features that I will talk about briefly. It is still costly for patients who do not have coverage or they have partial coverage for the test because they might not have enough numbers of strips. And it cannot be done in younger children, so somebody else has to do it for them. As a result of that, the continuous glucose monitoring came as a very good alternative. The continuous glucose monitor system consists of a transmitter and a sensor. The sensor is inserted in the subcutaneous tissue. It measures the interstitial fluid glucose concentration, which links very nicely with the blood glucose fluctuation. And the transmitter will send the signal or the readings to another device. The advantages of the CGM or continuous glucose monitor, it does 1 reading every 1 to 5 minutes, which will generate few hundreds of readings per day, remarkably more than anybody can do on a SMBG basis. It does show the trend in a curve on a daily basis or multiple days in an overlay format to show where the blood sugar or the interstitial glucose is going up or going down, even when the patient is asleep or unaware of these changes. It does have alarm features for hypoglycemia as well as hyperglycemia with adjustable cutoff numbers. The sensor life is 1 to 2 weeks, so there's a significantly less number of self-booking. And then some of them needs no calibration and some of them needs only 2 calibration per day. Last but not least, it has a Wi-Fi connectivity which enable other caregiver, parents, or family member to monitor those changes on their loved ones when they're away from them, as well as enable the connection to the insulin pump. Again, the type 1 diabetes exchange registry shows clearly how the prevalence of using CGM, while did not change remarkably between 2011 and 2013, it has increased by more than 4-folds between 2014 and 2018. On the lower part, you can see the difference between 2011, 2012 in the white bars and 2016 to 2018 in the black bars. And as you can see, pediatric patients have the most remarkable increase in use. This is a picture of the combination of the transmitter and the sensor of the 3 available devices in the market now. They're very compact. They look very reasonable. They can be hidden under the clothes. And this is the transmitter that will be shown above the skin. And this picture here shows the new transmitter of one of the new transmitter of one of the devices that will be available by the end of this year. And you can see how much smaller and more compact, and it will be lasting for longer period of time and needing no calibrations. So those transmitter will send the signal either to insulin pump or to a receiver or to smart device such as a smartphone or a smartwatch. So those numbers can be seen all the times. This is the difference of what you can see with the daily curve of the CGM versus looking at 4 random number of SMBG. You can see easily how you will be missing severe hyperglycemia, episodes of hypoglycemia, and extended hyperglycemia if you rely only on the SMBG reading. Here's example of 4 days layout, and you can see consistency in this particular patient where there is nocturnal hypoglycemia and post-lunch hyperglycemia. This will help very much making the proper adjustment in insulin treatment. And this is the AGP or ambulatory glucose profile, where you can see bar chart with a breakdown of the reading in range or above range, or in the hypoglycemia. You can see the curve, summary curve for the 2 weeks period, or you can see the daily curve on a day by day. And this is much more informative than what you can see from a traditional SMBG. What are the clinical benefit of CGM? The JDRF had the first or earliest important and big study, and they showed that using CGM for 26 weeks reduces HbA1c in adult patients. Results was not as good in younger patients, means pediatric and young adults. And the reason because less than 50% of those patients use the CGM on a regular daily basis. A recent study 10 years later in adult patient showed also a very similar curve where HbA1c has shifted to the left, and in numbers, after 12 weeks, HbA1c has dropped by 1.1%. After 24 weeks, 1% compared to SMBG from 0.5 and 0.4%. So that's more than twice improvement. JDRF has done another study to look at the effect of CGM on hypoglycemia, and this time they looked at excellent controlled patient with HbA1c below 7%, total of 129 patients, 26 period, and they look at the drop in HbA1c without a changing in hypoglycemia, and the CGM was clearly superior. They also looked at the improvement in hypoglycemia without worsening in HbA1c, and once again, CGM was superior to SMBG. Another study done only in pediatric patients and those with good control HbA1c below 7.5%, and they looked for a 26 weeks effect. And once again, remarkable reduction in hypoglycemia, important to drop in HbA1c and SMBG in the CGM group compared to the control group. Now, does the CGM help poorly controlled patients, or it's only good in well-controlled patients? This study looked at 21 patients with type 1 diabetes who have HbA1c more than 9%. They followed them for 12 weeks. The average use of CGM was 4.26 days per week, not even a continuous use. And they found there was a significant drop of HbA1c by almost 1.5%. Now, this is from type 1 diabetes registry again, and it shows across the lifespan between childhood and patients, adult patients, stratified into 4 groups: multiple daily injection without CGM, insulin pump without CGM, and the same with CGM, multiple daily injection and insulin pump. And you can see in all age groups, patients on CGM have the lowest HbA1c than the rest of the patients. So one of their conclusion, which I have put in bolded writing here, that continuous glucose monitor without insulin pump has better average HbA1c than insulin pump without continuous glucose monitor. So if you are in the situation of starting one device on your patient, it might be more appropriate to start a CGM first and then plan for the insulin pump later. So in summary, the clinical benefit of CGM reduces HbA1c in adult patient as well as in adolescent patient, and it reduces the hypoglycemia. Should CGM be worn on a continuous basis? The answer is no. From this good study of 160 patients with type 1 diabetes between children and adults, and they were randomized into 3 groups. One group who used the CGM continuously, one group used the CGM on a biweekly basis, and a controlled group. And they showed that the drop in HbA1c was the best in the continuous CGM use group. It was still important and significant in the group that used the CGM intermittently. And of course, the control group has the least improvement in HbA1c. How early should the CGM be started on a diabetic patient? Again, this is a nice study of 400 patients with type 1 diabetes. Most of them were children. They were started on CGM within the first year of diagnosis, and they wanted to look at 2 parameters. The first one, the ED visits in the 2.5 years following the onset of diabetes, and the drop in HbA1c. And you can see that those who were started on CGM has more than 50% reduction in ER visits. And when you look at the HbA1c, you can see that the group with the CGM, regardless whether they were on pump or multiple daily injection, had a lower and sustainable drop and improvement in their HbA1c than the group without CGM. What are the other benefits of CGM beside HbA1c and hypoglycemia? It has very important improvement on the hypoglycemia confidence, hypoglycemia fear, and reducing diabetes stress. It is also found to be cost effective. And the intermittent scan CGM was found to improve treatment satisfaction, result in less work absenteeism, and improve quality of life. This is an adult patient. In pediatric patient, there was an older study from JDRF that shows no difference in quality of life. However, a more advanced study looked at the CGM with the Wi-Fi connectivity, and they found that it does improve quality of life, it does reduce family stress, and it improves the parental sleep pattern as well. What are the other benefits of CGM? It can be a good alternative, maybe better alternative than HbA1c in those 3 categories I have put. When you see discrepancy between your glucometer average glucose reading and HbA1c, you have to do CGM. When patient has a blood condition that might affect with the HbA1c reliability, you need to do CGM. And if you need to look for short-term data of a week or 2 or 3, you need to do a CGM. And now with the hybrid insulin pump and hopefully soon coming closed loop, you have to have a CGM to have the full system in effect. So what are the recommendations for the CGM? The American Diabetes Association in the most recent standard of care, they have clearly identified that CGM is known to lower HbA1c and hypoglycemia in adult patients with type 1 diabetes. And it should be considered in all children and adolescents with type 1 diabetes, regardless whether they're on multiple daily injection or insulin pump. Additionally, they recommend using it in pregnant women who have type 1 diabetes for the benefit of the mother and the baby as well. However, they have recommended that the CGM should be used as close to daily as possible. And for the intermittent scanning CGM, it should be used more than every 8 hours per day. SPAD has similar recommendation that CGM is particularly, I'm sorry?
I'm afraid we've gone over time. So we have like 1 minute left, please.
Yeah, I should be done in less than that. So SPAD has similar recommendation of the importance and usefulness of CGM in pediatric patients and those with hypoglycemia and awareness. They don't have as strong feeling about the ISCGM. And then the ACE recommendation, again, they support the finding that CGM improve HbA1c and hypoglycemia in all patients with type 1 diabetes. It is also cost effective, and then the coverage should be enforced on the health insurance companies. So in summary, SMBG should be done 6 to 10 times per day in patient with type 1 diabetes for proper insulin dosing and to follow the abnormal readings. CGM is a very useful option that helps in lowering HbA1c, reducing hypoglycemia, and improving quality of life. And CGM should be considered in all children and adults with type 1 diabetes, adults with hypoglycemia and awareness in particular, and those with high HbA1c, and should be considered for those who want to do the hybrid insulin pump. Thank you very much.
Thank you, Dr. Walid, for the nice presentation.
Okay, so most of them, they ask about the insulin. So, for example, they ask when to select 70-30 insulin, the premixed. So,
I see.
Victoria.
So the talk was mainly focused on type 1 diabetes today. And in type 1 diabetes, we don't really recommend the 70-30 because of the lack of flexibility and ability to adjust it to the meals and the requirement. But if we're talking about type 2 diabetes, then yeah, of course, there's a role for 70-30. And it depends. It all depends on the, it's very individualized. It depends on how much patients eat. You can use the 70-30 or the 50-50 and so on. But there is definitely a role there, yes.
Okay, good. There is one question I don't understand, but I will just I will read it. He said that when can we use oral hypoglycemic drugs in pediatric diabetic patient? And he said that, I think this is a physician. My patient is 18 years who has been treated with metformin. So
I'm not a pediatric endocrinologist. Maybe I would direct the question to Dr. Walid. He can answer.
Okay, good.
Yeah, can you hear me?
Yes.
Yeah, so actually metformin has been used in practice off-label for patients who have type 1 diabetes, but who also are overweight and require significant high doses of metformin. So there is insulin resistance in type 1 diabetes because of obesity. So once patient requirement exceeds, say, 100 units per day, and we still need to give them more insulin, we put them on metformin in combination. However, you have to be careful that your patient does not have ketone, because metformin becomes almost contraindication if ketone is moderate or higher.
Okay, good. Just last question for Dr. Iba regarding Daphne. Is there is any preconditions for joining the program in Desmond? Suppose we want to send some of our health educators to join this program, Dr. Iba.
So DASMAN is the training center for the whole of Middle East. So we welcome all people to join us, and we will send you all the regulations, whatever. You need to have a cohort of type 1 diabetes and a qualified diabetes educators, and then that's it. We promote education everywhere around the world.
Good. Okay. So, okay, you can conclude that, Dr. Amir. So thanking our speakers.
If I have a very short question from Dr. Reem.
Yes.
May I have?
Sure.
Dr. Reem, I want to know that if we are in a part of the region that there is no reimbursement for analog insulin, okay? Do you think this is worthwhile to prescribe analog insulin instead of human insulin just to be safe from the hypoglycemia? What's your exact idea about this matter?
I think the clinical evidence that I've shown you is not really that strong to push for when it comes to cost and effectiveness. I think the evidence is more towards the flexibility, the convenience, quality of life, with the once daily glargine compared, for example, to the twice daily MPH. So I think I would, if it's in a part of the world in which they're very expensive, I don't feel that the evidence that we have so far is really strong to push for the analogs when it comes to hypo. And I think it's more as what Dr. Iba showed us about the education and how to teach the patient how to, to train and how to adjust their insulins to their meals. And it's more important. And the studies on hypoglycemia have shown much stronger effects with education compared to what we see with, comparing the analogs versus the human.
And we have actually seen in the Daphne program that, if you use glargine once daily, you don't have as good, A1C control as NPH twice daily. So we promote use of the glargine twice daily in all of our type 1 diabetes patients.
Good. Thank you so much. Thank you so much. It was a very nice session for me, and it's very informative. The question of the session was how to minimize the hypoglycemia in type 1. As I learned from this session, the most important thing is education,
Yes,
and
yes,
education.
yes.
Thank you so much. Thank you so much.
Yes,
everybody,
yes. Thank you.
Goodbye.
Thank you.
Have a nice evening.
Thank you very much,
Evening.
everybody.
Thank you. Goodbye,
you.
everyone.
Okay, Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. My name is Muhammad Hassanain. I'm a consultant endocrinologist at Dubai Hospital, and I'm also an academic with Gulf Medical University as well as Cardiff University. Let me share my screen. I'm delighted to take part now of the Abbott Symposium regarding flash glucose monitoring. How can it help for a better and safer diabetes? Obviously, following the excellent session of type 1 diabetes presented by my colleagues from Saudi Arabia, Kuwait, and UAE, my job is a lot easier. So let me go through my thoughts. I'll start with a case scenario. A person who's type 2 diabetic, aged 52 years, and he attends your clinic concerned about his diabetes. He checked his blood HbA1c in the lab, and he's conscious that it's 7.8, and it was recently also raised at 8.3. He's on maximum dose of DP4 inhibitor and metformin, and he's also on Novomix 30, 28 units with breakfast and 18 units with dinner. He started 4 months ago, and he's concerned about his control, because while he thinks he needs to push his insulin more, he's been recently getting hypos when he's busy with work. So the question really is, how can we get this person better control? So I would like to summarize again the points that of the case history. Someone on dual therapy, oral therapy, as well as a biphasic insulin twice daily, and his control is not good. So should we maybe increase the dose again, or change the type of mix, or change him to basal bolus? Or perhaps we should change his DP4 inhibitor to a GLP-1, or even possibly add an SGLT2 inhibitors. Of course, they're all valid answers, but the reality is this particular person, poor control, is not a surprise. We have heard today many presentations about the control in people with diabetes, type 2 and type 1, and how the reality is many of them are not achieving control, even though maybe they are treated in best centers in the region here or globally. And when people in UAE as well as in Kuwait, over 500 doctors and patients were asked about why they're not achieving their targets when they are on insulin treatment. A very good proportion has responded to lack of self-management of ability in insulin dosing, lack of support, and of course, hypoglycemia is a big feature, whether fear hypoglycemia or occurrence of hypoglycemia. So certainly this is a big problem. And the least of the problem was the cost of monitoring. So when it comes to blood glucose monitoring, Dr. Walid Kaplan have just gave us an excellent presentation. And I think in my mind, blood glucose monitoring, regardless of the type of it, helps if from the patient point of view, to understand their diabetes, to change their behavior, and from us as healthcare professionals' point of view, better assessment and better optimization of therapy. All of this will have an impact on metabolic control, on safety, on quality of life, and will lead to a better economic values. Why? Because poor control will cause admissions, and admissions cause far much more than the cost of the blood glucose monitoring, even if it's a continuous glucose monitor of flash glucose or different types. So for us as diabetologists or doctors, the major reason we say I'm unable to push my insulin dose higher is we feel that the patient is not doing the monitoring enough. Why the patients are reluctant to do the monitoring? Because you hear this message very frequently. Doctor, look at my fingers. Look how much they are sore. How many years and many times I've been stabbing my finger for the blood test. Doctor, I forget. Doctor, it is expensive. So many reasons that the persons would throw in because of lack of conviction. And sometimes actually they say to us, well, I did my blood glucose tests and went to the doctor. They never looked into it. So it becomes very, very much a problem. So many physicians, when they were asked, why are you not increasing or intensifying the insulin therapy? And many of them are saying, well, the lack of patient monitoring when insulin intensification is required. So clearly, blood glucose monitoring can help minimize physicians' inertia by providing timely and valuable information that can help to change behavior, choose the right treatment, and adjust the treatment dose. So Elliot Jocelyn, we all hear about the Jocelyn Center. Elliot Jocelyn is the founder and he's one of the eminent diabetologists, and he said that almost 100 years ago, the diabetic who knows the most lives the longest. So we need the knowledge, and it's very important that we have the knowledge. And we also need to think out of the box. I gave you a case and I thrown in lots of options for therapy, when in fact, in my mind, I don't need any extra therapy for this patient. I need to know more about my patient. And part of knowing more is to know more about his blood glucose profile. I think Dr. Kaplan in his presentation have gone through the history of the blood glucose monitoring development over the years. And I personally feel that one of the big problems of blood glucose monitoring is the timing of the test. You will see that the mean glucose of all of these individuals is the same. But with one of them in blue, the fluctuations are small. In the other one, the fluctuations are high. So it really depends on what time of the day you check the blood glucose figures. If you check it here, for both, it might be the same. But if you check it here, it will be very different for both. So really, it's quite important that we know what we do. Continuous glucose monitoring in the past was a bit of a nightmare, similar to this picture. You would to see the figures and you say to yourself, where do I start and how can I finish? Different lines, each line represent a different day, and you're trying to make heads from tails for this particular person. But luckily, with better technology, the outcome is a lot better. Blood glucose monitoring was like a roller coaster. Continuous blood glucose monitoring was giving us lots of information about how our patients are going from high to lows. With flash glucose monitoring and with the curves that we have for the AGP, we now have much better understanding of the profile of the person and the trends of the individual. This individual obviously have fantastic blood glucose control if they do not have diabetes during pregnancy. In fact, this particular person is one of my pregnant patients. So nevertheless, this person is still out of control because here the figure is between 70 to 120. So obviously the changes and the blood glucose fluctuations depend very much on the case of every single individual. Patients love flash glucose monitoring for many reasons. They stick it on their arm, it stays for 2 weeks, they don't need to check again, they do not need to calibrate, they do not need most of the time to double check. So the acceptability by the patient is very high. For us as healthcare professionals, we love the data that is provided by the CGM, whether it's flash glucose monitoring or a CGM. The fact that it's easier and the fact that its cost is not excessive, it also makes it more accessible to more number of people. But of course, it is more expensive than SMPG. But you cannot expect that the amount of information you get from a flash glucose monitor to be equivalent to what you can get from an SMPG, which is dependent on the number of times the person check. But here, I do not need to do more than simply download the figures by the simple action of screening my figures with my reader. And I would like to share with you here our personal experience from Dubai Hospital, where a few years ago, we had 180 patients on a management of what we called it optimum care. We were looking for high-risk patients during Ramadan, and we provided them all with optimum care, which included flash glucose monitoring, patient education, as well as dose adjustments by the doctors who are well trained and with expertise in the field. And with flash glucose monitoring, you can get the time in range, above target, in target, or below target. And as you can see, here is our different groups: patients with cardiovascular disease, patients with gestational diabetes, patients with diabetic nephropathy, patients with type 1, and patients with type 2 diabetes. Blue is their figures during the sensor put during the month of Sha'ban, and red is the sensor readings during the month of Ramadan. And I share with you here the before Ramadan, because I don't want to make the presentation as a Ramadan study, but here you have very important information. So in normal days, 61% of our patients were above the target. That was for the non-pregnant women was between 70 to 180. So of course, this is something that we need to improve on. And when you look into specifically type 2 diabetes patients on insulin, similar to the case scenario that I've put in the beginning, you will find that almost 70% of them are above target in normal days out of Ramadan. So it's really important that we remember that there is a lot that we need to improve on, because postprandial hyperglycemia, even if the average is good, but postprandial peaks could be problematic. And classically, thinking within the box, you would always say continuous glucose monitoring is required for a patient with type 1 diabetes. But the reality is we need it also for so many patients that are with type 2 diabetes on insulin or even not on insulin. Because as you can see here, this graph tells me about how high is the blood glucose levels and at what time of the day. So clearly this person during the eating hours, yes, this data was during Ramadan, but it tells me that during the Asr and Maghrib time, late afternoon to evening, he was or she was okay. But afterwards, see the peak, and it remains high throughout the night as well. So such information will help the person to perhaps change their behavior, adjust their food, adjust their physical activity. And for us as clinicians, we will be able to better adjust the treatment during the eating hours. And here is some data that's been published recently, and I will share it with you, as well as it being data with Abbott on diabetes care. All the results of the downloads across the globe have been analyzed, and here is the data from the Middle East. 16,800 readers with huge amount of sensors and huge amount of monitoring hours. So I would like you to look here into this chart. Red is Middle East, blue is all countries. And here is the daily scans. So we do scan the patient do scan themselves frequent enough compared to the rest of the globe. And we see a reduction in HbA1c. However, that reduction in the Middle East is not as high or as good as the reduction in the rest of the globe. Perhaps it's the lack of education that Dr. Ibal Ozairi has mentioned in her presentation, as well as Dr. Reen. When you look here into time above target, so that reduced in globally by 44%. For us, Freestyle Libre helped people to reduce their time above target, but by 14%. So certainly in our region, there is more to be done. Time within range. Here you see that we are less with time within range in compared to the global readings. So it certainly shows there is improvement, but there is certainly room for further improvement. You can see it increases in time. So when you ask yourself, does it help my patient? Yes, because here the percent of time in range when the sensors were started was low, but as it increases in time, it improves a lot better. But nevertheless, there is a gap that needs to improve. When it comes to hypoglycemia, we also have a problem which needs to be addressed. So in all essence, there is plenty of points that need to improve, whether the hypoglycemia is below 70 or below 50. We certainly need to get our targets better, because we do have a problem with highs and we do have problems with low. So in our particular study, the 180 patients that we studied, we've learned a lot of lessons from the sensor data. For example, the timing of the hypoglycemia. So during normal days, most of the hypoglycemia are during the night, followed by the active time in the afternoon. There was a little difference during the day between morning to lunchtime, lunchtime to evening, or evening to midnight. But clearly, the night time was the worst time regarding the hypoglycemia. That was not the case during Ramadan, where you see that the worst time was the late afternoon. So this flash glucose monitoring for our patients who want to live a normal life, whether they were fasting or not, will give us valuable information on when is the highest risk for highs as well as for lows. But we've learned also from the studies that hypoglycemia could be prolonged and could be completely asymptomatic. And people were wondering, is it true hypoglycemia, or does the sensor exaggerate the hypoglycemia? Well, we have looked into this, and the company have also looked into this. The accuracy for the third generation sensors are different. This is the accuracy for, sorry, let me just go back. So this is not the third generation sensor, this is the first generation sensor. Here, the accuracy when it goes to below 50 or from 50 to 80 was a touch high, with 12.6 milligrams per DL of mean absolute relative difference. In the third generation sensors, and Dr. Kaplan have shown us the photos of how thin and how smart the new generation sensors that should be available in our region in the future are better when it comes to accuracy, even in hypoglycemia. But we also know that during the beginning, during the first few days, the accuracy is slightly lower than in the middle or in the late part of the sensor. And that's something important when you have your patient installing the sensor for the first time. But there are hints in the reader that can help us to identify, is it a true hypoglycemia or not? So looking into these arrows is really quite important. Is it rising quickly, or is it just rising, or is it stable? The direction of the arrow is saying to us, it's not just about the figure now, But how is this figure in relation to the previous half an hour or an hour or 15 minutes? So if it's saying to us it's falling or falling quickly, then it is perhaps time to be cautious. It is saying to us it's been stable, then I maybe need to think again. But do not forget as well that to double check with your patient the subtle symptoms of hypoglycemia. And if hypoglycemia symptoms are become less recognizable, we need to talk to our patients to perhaps double check. That is the standard advice. If you have a hypoglycemia that you feel it's not true hypoglycemia, if you have access to a blood glucose monitor, double check. If you don't, assume it is and act upon it without delay, whether that is during normal days or during fasting days. So the question really is, can flash glucose monitoring as a type of CGM improve blood glucose profile? Does it truly help? After all, the latest technology allows the information to be delivered from the reader to the PC or the laptop through the application and through the cloud, and from my patient own home or holiday or office, I can see the readings myself in my clinic. And I'm delighted to share with you this study recently published 2 years ago by Timothy Dunn and his other co-authors, including Ramzi Ajjan. I think many of you know Ramzi, who's a diabetologist in Leeds of a Jordanian origin. And it's great to see that the estimated HbA1c has improved in those who were on the flash glucose monitoring from 8 to 6.7. And also that the rates of hypoglycemia reduced by 40%, specifically the more clinically relevant hypoglycemia with a blood glucose of less than 3 millimoles or 54 milligrams per DCL. So I would also like to share with you our hospital, Dubai Hospital study, which is today is available online from Diabetes Research and Clinical Practice. And I would like to show you the rates of hypoglycemia. Blue is number of events of more than 10 events, and that was 41%, reduced to 29% with optimum care, including the flash glucose monitoring, the patient education, and the dose adjustments by the diabetologist. The median range of 6 to 10 episodes did not change. But what is good that 0 hypoglycemic events increased from 8 to 12%, and the 1 to 5 episodes during the censored duration of the 2 weeks increased from 29 to 37.5%. And all this reflected on the percentage of people who had less hypoglycemia. So here in green, 62% had an improvement in frequency of hypoglycemia or in time of hypoglycemia compared to 33% who had a deterioration and 9.5% had no change. So if you look into the difference between this and this, we had double the number who improved compared to those who gone worse. So in all, it's very good, specifically if we know from our study, the lab HbA1c improved marginally, but that was statistically significant. So really, it's quite important that we remember that providing our patient with flash glucose monitoring coupled with education can lead to improvement, whether it's in type 2 or in type 1. And I would like to share with you a couple of the latest posters presented at the ADA regarding Freestyle Libre as a flash type of glucose monitoring. The first presentation was by Professor Bergenstahl from the USA. Everybody knows about him. And here it's a study in type 2 diabetes. They looked into, since the prescribing of the Freestyle Libre in a large cohort of patients, how did that impact on reduction in inpatient as well as in outpatient emergencies? and acute diabetes events, including all-cause hospitalization. And you will see here that here in blue is before. So here is acute diabetes events. And here is 180 days, 6 months after the start of the flash glucose monitoring. And you can see quite a big difference in events per patient for what? For acute diabetes events, inpatient or outpatient emergency. And here is the hospitalization, and that also improved, and both of them have improved clinically and statistically to a very significant level. Another important study that looked into HbA1c reduction associated with Freestyle Libre in people with type 2 diabetes who were not on bolus insulin therapy. So they are either on basal insulin or not on insulin at all. And here in this particular study by Wright et al., they looked into to assess the HbA1c following Freestyle Libre prescription in people with type 2 diabetes and poor glycemic control, not using bolus insulin. And I have picked up these two specifically because they are relevant to the vast majority of type 2 diabetes patients that we see in our MENA region. Not many patients are on bolus insulin. The vast majority are on basal or on mixed insulins of some sort, or on oral therapy or GLP-1. And here, the interesting point is when you look into the data that it has improved over 180 days, regardless of the HbA1c, and the improvement was higher in those who were on HbA1c that, I'm sorry, let me just unhide this slide because it's important that we see it as well. Yes, here you can see it, that the improvement happened regardless of the level of the HbA1c. The change in HbA1c for all of them was 1.38, which was statistically significant, and it occurred regardless of the level of the HbA1c for all our patients. So, ladies and gentlemen, I'm coming to the end of my presentation. Blood glucose monitoring, again, I would like to stress, for people with diabetes, it is essential to help them better educated and better understanding their condition and enable them to change their behavior. For us as clinicians, glycemic assessment and optimization of therapy with a positive impact on overall glycemic control, safety, including hypoglycemia, quality of life, and we saw less hospitalization, less events, which obviously means less cost. So it is important for all of us to remember that flash glucose monitoring as a model of CGM could be good support for people with diabetes for all of these aspects that I've just mentioned. It is currently widely used, but we need to optimize our use through regular download of the data and regular empowering of our patients to analyze the information and to better communicate with us, transferring the data electronically via the cloud, via WhatsApp, via a message or text message, email, whatever. We also need to train our patients to know how to troubleshoot during times of hypo or hyperglycemia. None of this can happen without structured education. The tool on itself will give information, will give data, but the tool will not be able to tell the person what to do, and that's why structured education is essential. I would like to reflect on what Blond said 20 or 18 years ago. It's not the collection of blood glucose data, but rather the effective use of the blood glucose information for making clinical decisions that leads to improvement in diabetes control. And if you were to think how many years back did Lord Kelvin say, if you cannot measure it, you cannot improve it. And if you measure it, then you must do something about it. So really, the question is probably not whether we use blood glucose monitoring, but rather when and how to use it to its greatest effects. And with this, I'll leave you with a photo of my beautiful city, Alexandria. Thank you all, and I'm happy now to take any of your questions. I think we have probably a minute or two for some questions. I know that we're behind overall with the timing of the conference, but in general, I think, let me go through some of the questions which will be sent to me via technology, via WhatsApp. Okay, so let me first stop sharing this so that we can see each other and look into the, so one question is, what about accuracy of flush blood glucose monitoring devices and how can it be measured? Well, the accuracy is repeatedly measured by the organizers, sorry, by the companies, in studies by them as well as by the regulatory authority. And I've shown you the slide of the relative accuracy regarding different levels of blood glucose. When the blood glucose level is a bit too low, the accuracy is slightly less perfect. And if in doubt, the patient obviously need to double check with SMBG. The third generation sensors accuracy is better. Another question is asking about the accuracy of the figures in people who has heart failure. There's no difference in the accuracy of whether the person have heart failure or renal impairment or anything else. Can there be a difference in the sugar level when checked in both hands at the same time? Potentially yes, because of time. At the end of the day, it's a material, it's a machine, so potentially there could be slight differences. If there are huge differences, then certainly it's a matter of the technique or the strip itself. I think I do not see more questions. These are the questions that have been sent to me. I'd like to thank you all for your attendance, and I invite you all to enjoy our last session, which probably will be the dessert of the conference with the eminent moderators and the eminent faculty on the last session. Thank you all and enjoy your evening.
مساء الخير. Good evening, everybody. First, I would like to congratulate all the committee members and organizers for the successful Congress. I am Mohammed Sandid, endocrinologist, president of the Lebanese Diabetes Society, IDF MENA chair-elect. I am very proud to share this session with my friend, Professor Zaman Sheikh. So welcome to the last session, session 8, in our virtual MENA Congress. So 3 speakers will discuss in this session the following topics. The first one is entitled Prevention of Diabetes Through Lifestyle Measures, given by Professor Abdulmajid Sharabi. The second talk about therapeutic approach in the prevention of diabetes, given by Professor Noad Saliba. The last lecture in enjoying food while losing weight, the challenges, by Dr. Wafa Helmi. So we can collect the questions to the end of the session. Now, I invite my friend, Professor Zaman Sheikh, to introduce the first speaker. Please, Professor Zaman.
Thank you very much, Professor Mohammad Sandid. First of all, I congratulate organizing committee for organizing this fabulous IDF MENA virtual congress. Dr. Jamal Bilkadir and his team deserve special congratulations for formulating this scientific program. First speaker is Professor Abdul Majid Sharabi. He is Professor of Endocrinology and Metabolic Disease. He is Dean of Medical School, Ibn Zohar University, Agadir. He is former head of Diabetes Endocrinology and Nutrition at Ibn Sina Hospital, Rabat. He remained past president of Marocaine Society of Diabetes Endocrinology and Nutrition. His topic is very crucial. It is prevention of diabetes through lifestyle. Now we know that there is no cure of diabetes. There is no treatment, no cure of diabetes. Even treating the diabetes up to level of producing hypoglycemia, such a meticulous control will not prevent complications. So only solution remain to prevent the type 2 diabetes whenever it is possible. And let us see what lifestyle plays role in prevention of diabetes mellitus. So please, Professor Abdul Majid, I request you to restrict your talk kindly for 15 minutes, and all the question answer session is at the end of this program. Thank you.
Thank you, Professor Zaman. Dear colleagues, Assalamu alaikum. It's my pleasure to share with you and discuss some information about prevention of type 2 diabetes through lifestyle measures as demanded by our President, Professor Jamal Belkhadir. Here is the agenda of my presentation. First, how is the relation between lifestyle and diabetes? Then, the main results at the international level, followed by some results at the MENA region, and I will conclude with challenges in real life. Lifestyle factors have variable negative impact on vessels, liver, fat tissue, muscle, brain, and microbiota, which constitute a metabolic, endocrine, immune, neural network, and synergize with insulin resistance in promoting beta cell damage. The IDF reported in its last Atlas edition the major randomized primary prevention trials in type 2 diabetes using lifestyle modification. First, the oldest one, we have Dakin diabetes prevention study with the 2 extended study. What does it mean, extended study? We have for Dakin diabetes, lifestyle modification and intervention during 6 years. Then we stop the intervention, but we continue the following, the study of with following the patients. Here we have 20 years following, and here we have 20 years following. So here 20 years, so 14 years after stopping intervention, and here 17 years after stopping intervention. The second study, we have the diabetes prevention study in Finland, also with its extensions. We have also in the United States of America, the famous diabetes and very known diabetes prevention program. And in India also, the Indian diabetes prevention program. And we have also the Pakistani diabetes prevention program and the prevention or Pakistani diabetes prevention study and the prevention of type 2 diabetes by lifestyle intervention in Japan. We can also add 2 other important studies. The first one, lifestyle intervention on metabolic syndrome in Italy, and European diabetes prevention study EDIPS. But the most important conclusion of all these studies is lifestyle changes have significant effects on the prevalence of type 2 diabetes with a global relative risk of 0.53. This prevention effect has been demonstrated to be sustained for many years after active intervention. The cumulative incidence of diabetes mellitus during following up in China, Dakin diabetes prevention outcome study, confirmed that fact even after 14 years of follow-up. So what we can name the legacy effects. We have here the 6 first years for intervention with good results. difference between control and intervention. But here we stopped the intervention and we followed for 14 years. And even we stop the intervention, we have still the difference between the control and the intervention group. That's, as I said, the legacy effects. Moreover, in the same study, cumulative incidence of cardiovascular disease deaths shows a significant difference between control and intervention group starting 6 years after active intervention. Here also, we have 6 years. First years we stop the intervention, but after 6 years after stopping the intervention, even we stop the intervention, we start to have a huge difference between the control group and the intervention group, and we have decreasing of CVD death. Then legacy effects. In this other study, lifestyle intervention with low carbohydrate formula diet reduced pre-diabetes prevalence stronger than lifestyle diet alone, and is effective for type 2 prevention. Moreover, in DAKIM diabetes prevention study 6-year follow-up, we can notice the significant difference between the control and the intervention groups. However, there is no difference between diet, exercise, and diet plus exercise. Does it mean that it's not necessary to combine diet and exercise? The answer is no, according to other studies showing the role of physical activity. This is one meta-analysis. So, lifestyle modification prevents type 2 diabetes through weight loss. In this meta-analysis, weight loss is significant in the intervention groups. Moreover, there is a linear relation between weight changes and the incidence of diabetes after 1 year follow-up of the Finnish National Prevention Program. More than the effects on diabetes lifestyle, changes can improve other parameters like blood pressure and lipid profile, both in men and women. However, other studies don't find any change of blood pressure and lipid profile. In MENA region, we can consider that the prevalence of type 2 diabetes is the highest in the world, as mentioned by Professor Fawad this afternoon. In addition, researchers on NCD, cardiometabolic problem, diabetic problem here, and oncology, and NCDs, non-communicable disease, are growing, especially in the Middle East. On the other hand, NCD mortality represents a huge percentage in MENA region, 80% in Morocco, for example, 90% in Lebanon. That's why the United Nations consider NCDs as one of the major challenges for development in the 21st century and focus their actions on strategies and political actions like United Nations political declaration on NCD in 2011 and United Nations Task Force on NCD in 2013. The MENA region includes the south of Mediterranean Sea, which refers to the traditional and very known Mediterranean diet. The Pre-D-Med Plus study shows that the mean energy intake depends on the adherence of the Mediterranean diets. We have decrease of energy intake according to the importance of adherence on Mediterranean diet. Moreover, valuable components as monounsaturated fatty acids, polyphenols, fiber, improve endothelial vascular activity, and finally, diabetes outcome will be improved. One of the most known nutrients in Mediterranean diets is olive oil. It has anti-diabetic properties, which can enhance it by physical activity. By the way, the prevalence of physical inactivity among adults in MENA regions is very high. In average, we can consider that more than the half of the population doesn't practice exercise. For example, here in Morocco, we have 38% of adults more than 18 are inactive. In King Saudi Arabia, for example, we have this here in study, 82% of adults are inactive. But more surprising is the prevalence of physical inactivity among children and adolescents. Here we have 80% of inactivity in Morocco and Palestine and 90% in Egypt. This physical inactivity is more prevalent in female, even among adults and adolescents, which can maybe explain the high prevalence of type 2 diabetes in women in MENA region. In this Lebanese study, rates of physical inactivity among adults diagnosed with diabetes and at risk for developing diabetes confirm the role of lifestyle changes in the prevention of type 2 diabetes. We have, with existing diabetes, we have 55% of inactivity versus only 46% of inactivity with no diabetes. That's why Morocco, as many countries over the world, has chosen reasonable targets against NCDs by 2030, like decreasing physical inactivity by 10% and diabetes by 15%. To conclude, physical activity is determined on the prevalence of type 2 diabetes. There is a relationship with workability and other factors present in the neighborhood, like a green area, air pollution, social support, and recreational facilities. In short, our task as health professionals is to implement with effectiveness and sustainability several programs to reach the goal which is difficult in the real life. Indeed, here is as an example an overview of suggested strategies to build on successes and overcome challenges to impact of National Diabetes Prevention Program, showing some challenges with potential solutions. I think that one of the big issues is to use digital interventions for diabetes prevention. It's the case, of course, now with the pandemic situation. Indeed, some of you are now following this meeting through their mobile phones, so I believe that mobile health intervention can and must be the main way for diabetic education, especially in prevention. Thank you very much for your attention and hope to receive you in Morocco next year, inshallah.
Okay. I am delighted to introduce my colleague, Professor Nuhat Saliba, who will present the therapeutic approach in the prevention of diabetes. He is MD, RCPC, FACE, Fellow of the Royal College of Canada and the American College of Endocrinology, member of the Committee for Diabetes Guidelines of Canada. He has many publications and many studies. A past president of the Lebanese Endocrine Society and co-founder of the Lebanese Diabetes Society. Dr. Saliba, the screen is yours, please.
Okay. Thank you. I want to thank really the organizing and scientific committee of this nice symposium. And I really have to congratulate those who are still there at the end of this session. I know it's not easy. And I would like to apologize before starting. I was not really aware of the whole program. I was invited a little bit late. And I noticed that during a pharma symposium, the Professor Jalal already talked about my session when addressing the use of metformin. So I had to hide at the last minute some slides in order not to overlap with everything. So I want to apologize for that. Now I was given the task of talking about the therapeutic approach of the prevention of diabetes. Now, just to start, I want to re-emphasize the importance of how to diagnose this condition. And you know, for several years, that was this kind of red area between what we call a normal glycemic control and the diagnosis of diabetes. And this area called the pre-diabetes for long was always a subject of controversies, what to do exactly in those cases. But I think with time now we realize that it's a pre-disease condition that has to be addressed in a different way than we were doing previously and a little bit more aggressively. And I would like to talk a little bit about it. And you see on the other side that for some years now we adopted the hemoglobin A1C as an important tool also for considering the diagnosis. And this helped a lot to find many more patients that were not really diagnosed, but the classical fasting and 2 hours OGTT. And just to remind everybody that, yeah, hemoglobin A1C is a fantastic tool, provided that you have good standardized methods in your countries for the hemoglobin A1C, and that everybody is aware that we can have false increase and decrease in the A1C. And also this realize that we can have a lot of discordance in results. So we see that many people identified as having diabetes using A1C will not be identified as having diabetes by traditional glucose criteria and vice versa. Now, when the results of more than one test are available and the results are discordant, we emphasize that the test whose result is above diagnostic cut point should be repeated, and the diagnosis made on the basis of repeat tests. Now, this slide already you have seen it. It's a very old slide, but I really like it very much because it gives us a very good idea about the natural history of diabetes, and we understand better what is happening there. Now, for the sake of not repeating too much the same things, I would like just to remind you that by the time that we are doing the diagnosis of the condition, we realize that sometimes it's too late because we have a time length of around 10 years between what we call the pre-diabetes and with the approximately 5 years until full-blown diabetes. And before that, we see that the complications of diabetes, as was stressed in other lectures, starts well before the full diagnosis of diabetes. Is, as we know, we can have this glycemic state for a very long time. Now, just to go back to this is more and more discussed as at present, the pre-diabetes is still considered a pre-disease, but most likely with further scientific delineation, prediabetes may eventually be considered as a true disease state that will require more aggressive early intervention measures. And as we can see through discussions in committees, etc., most likely in a few years, we would start talking about diagnosis of diabetes and strong intervention, maybe at an A1C as high as only 6%. Now, it's important to stress also that we have always to consider the risk factors for type 2 diabetes, and there are many of these. The age more than 40 years, first degree relative with type 2 diabetes, members of high risk population, and here most likely it was shown that the MENA region is one of the highest risk population, and mostly with the places in low socioeconomic status, history of prediabetes definitely, gestational diabetes and delivery of macrosomic infant, presence of end organ damage associated with diabetes. As we said, it can occur long before the diagnosis of diabetes. Let's not forget the presence of vascular risk factors, the metabolic syndrome that you know about. I'm not going to start it all over. Let's not forget also that associated diseases have to be taken into account, such as pancreatitis, polycystic ovary syndrome, acanthosis nigricans, hyperuricemia, non-alcoholic steatohepatitis, psychiatric disorders, HIV infection, obstructive sleep apnea, cystic fibrosis, etc. And you have also medication. All this to tell you that here in Canada, for already more than 10 years, we established what we call the Canadian Diabetes Risk Questionnaire. More than 10 years ago, it was distributed to more than 10,000 family physicians and diabetes centers. And we used a lot of statistics and epidemiologists. And we came across this kind of interesting questionnaire that doctors give to their patients in the clinics. And we assess, as you can see here, lower than 21 is a low risk, between 21 and 32 is moderate risk, and above this, and above this, you have a high risk. This is an important tool because it tells the doctor what would be the approach, how aggressive he should be into treating those patients before they become diabetics. And then it's important that for a very long time we saw a real approach between diabetes and obesity. They go always in parallel, and to some extent, a few years back, we were talking about the epidemic of diabetes. Now we know that more than 85% of patients at high risk of diabetes, prediabetes and diabetes, are overweight with a BMI between 25 and 50, and mostly the increased waist circumference is an additional marker, mostly in male more than female. You know about the atherogenic visceral fat, and more than 50% of those patients at high risk present features of the metabolic syndrome of insulin resistance. Let's come to the heart of the subject, where we look a little bit how many studies we have, mostly for the intervention studies that we have. Now I'm going to go quickly through these. Those two first ones were more interventional studies, lifestyle, but then in the most important one of these studies, which is the DPP and the DPPOS, which was an extension of 8 years. I'm going to go fast. They had the arm that used the metformin, where we can see a decrease of around 31% in the relative risk of diabetes. And here we like very much the number needed to treat. You see that you need to treat 14 patients to prevent one diabetes. The troglycazone, if some of you remember, it was the very first TZD that was on the market. There was a small branch, not significant, but then they did later on the second study, which is the troglycazone, the tripod study, using the troglycazone alone for the prevention of diabetes. And we were really astonished at that time to see a lowering of 55% in the rate of diabetes. You needed to treat only 5 patients in 3 years to prevent one diabetic state. We were very enthusiastic about it in those times, but you know that troglycazone was taken out of the market because of its toxicity. And here you have the study with acarbose. The acarbose study was started by a colleague of mine in Canada, Professor Chasson, but most of the study was done in China. And even with this, using this medication, alpha-glucosidase inhibitor, we noticed that we had also a decrease, a lowering of 25% in the relative risk of diabetes. Interesting. And then the DREAM study 15 years ago was done. It was one of the first study our center took, was participating in it. And we used 5,000 patients were used in this study. And really, very interestingly, we had a 62% decrease in the rate of diabetes. And the last one also using the orlistat that everybody knows, the Xendo study, that shows also a decrease of 30% in the relative rate of diabetes in those patients who lost 5% of body weight and more. Now, also, if we go back into the diabetes prevention trial, but the DPP-OS, we call over 15 years of treatment. And interestingly, also, a very long-term effective, very long-term effects of lifestyle intervention and metformin to reduce the incidence of diabetes was shown that it was remaining in the long term, raising this notion that started with the UKPDS study extension and the VADT that we might see some kind of what we call a metabolic memory or a legacy effect, stressing the fact that we have to be very aggressively intervening in those patients at a very early stage. Then why at that time metformin and TZDs were really used for the prevention of diabetes? You are all aware of it, that those two medications counter insulin resistance. I'm not going to go into detail. You know all of it, that the metformin is mostly dealing with insulin resistance at the level of the liver, and the TZDs were working mostly on the peripheral insulin resistance on muscles and adipose tissues. That was the rationale behind all these studies that was done there. But unfortunately, since that time, we didn't have a lot of other interesting big RCTs done for the prevention of diabetes with the new medications that we have on the market. But 1 month ago, I was on the virtual, watching the virtual European International Congress on Obesity, the ECOICO, that was on the 1st of September, and they presented a very interesting data, observational data that is really, I find, fantastic. In the UK, more than 500,000 patients in primary care with a BMI between 25 to 50, median age of 50, real people who lost 10 to 25% of blood weight, and they were followed for a mean of 8 years. It doesn't mean that all these patients lost, but those who lost between 10 to 25% using any method, like lifestyle changes, exercises, all kinds of medications, even 3% had bariatric surgery. But most interesting is the finding that those that achieved an intentional loss of 13% of body weight and maintained it experienced a significant decrease in the relative risk of developing diabetes by 40%. That raises always the issue that the most important factor in preventing diabetes and all the complications is the weight loss, first of all. Now, if we come, this has been also presented to you, what are the guidelines in different societies, but I will just go back to what we are doing in Canada, since I'm part of the committee for those guidelines. We issued the last ones in 2018, and we are updating it regularly. So what we are talking about, the therapeutic recommendations for us here in Canada, for sure not much different from elsewhere. First, in the individuals with prediabetes, pharmacologic therapy with metformin may be used to reduce the risk of type 2 diabetes. This is a grade A. There is a lot of evidence about it. However, the use of any other agent for pre-diabetic patients has not yet been endorsed by most of the guidelines for lack of long-term studies and evidence of efficacy. Third, however, and we had recently, I would say 7-8 months, a lot of discussion about this. It is a grade D evidence, which means that there is a consensus among experts. We allowed for the use of eventual other agents for individual cases if metformin is not tolerated, aiming mostly at weight loss at more than 5% sustained over time. Then it opens the door for any anti-obesity medication, the new classes of SGLT2 inhibitors, GLP-1 agonists, and we'd always say it remains a clinical judgment and based on cost-effective medication considerations for sure, depending on where you are and how much the population can afford these medications. And then to finish, my key messages is progression from prediabetes to type 2 diabetes can also be reduced in conjunction with lifestyle intervention by pharmacologic therapy with metformin. In most of the studies, as you was told before, around 850 milligrams BID is the best dose that was used in the studies. And with persistent benefits observed after more than 10 years of stopping treatment, mostly in the DPP. And again, we talk about the potential for a legacy effect, that if we intervene as soon as possible, we might really delay in the future the complications of diabetes. And other therapeutic measures can be considered. We say here off-label use on individual cases, mostly the new classes of SGLT2s, the GLP-1s, with the aim of achieving and maintaining more than 5% of weight loss until more convincing randomized trials are published in the future. Thank you.
Thank you, Professor Saliba, for your nice and clear and briefing presentation. Can I ask you 2 questions given by the audience?
For sure.
The first one, in absence of HbA1c testing, which we can rely on, FBS or 2 hours postprandial?
Which one? As I showed in one of the slides, that there is a big discrepancy between the results sometimes, and you have always to rely on the one value that was the highest. Let's say you can have an A1C of 6.2, but abnormal IGT, so you have to repeat your IGT, and if your IGT is positive, then most likely you talk of prediabetes, although your A1C is not you know, in the range that is for prediabetes. And let's not forget, and that's why I wanted to talk about the A1C measurement. Here in North America, we have a standardized measure that all labs are using almost the same kits, and it is standardized, so we don't have really discrepancies in the results. So it depends on the kits of A1C you have. We have to be careful about it.
Okay. The second question, please. How many years to pre-diabetes patient become diabetic? And if patient with pre-diabetes had lifestyle modification and take metformin, can prevent diabetes?
Yes, for sure. We showed now with the DPP prevention where they use the arm using metformin alone, other studies using TZDs alone, but for sure that all these patients, we always stress the fact that you have always to try the lifestyle modification, and in case of failure, probably to start medication. But then, sorry, your first part of the question was?
The first, how many years to pre-diabetes patient become diabetic?
So very important also that, like I stressed also, I showed you the questionnaire about establishing your risk for diabetes. And we have to always know that this is a continuum of risk that goes from the impaired fasting glucose to the glucose intolerance later on, and then to the established. There is no really cut point that said that, well, the patient is not. It is a continuum risk. So we know that patients with prediabetes, let's say at impaired fasting glucose, around most of 50% will become diabetic after 10 years, if nothing is done.
Okay. The last question, please. Prediabetes is now considered as a separate disease with a different pathogenesis. So some patients can remain pre-diabetic without progression.
Yes, some of them. It was known for long that patients can have what we call an impaired fasting glucose that can remain for several years without any change. But then we have always to go back to what we said. If the patient has a lot of the risk factors for diabetes, mostly the factors for cardiovascular complications, then he should be treated as such as a potential diabetic. Now, yes, there is no rule about at which time a patient is going to develop diabetes. But we know, according to the studies, that in general, they evolve little by little from impaired fasting glucose to a glucose intolerance before a full-blown diabetes. And it is a rate that was established in studies of around 4 to 5% of risk per year. Okay, so after 10 years, 50% are already diabetic. So it is not a different disease. Pre-diabetes, as I pointed in one of my slides, is probably a pre-disease, and with time, probably we are going to start talking about diabetic state at an A1C of 6% and possibly start aggressive treatment and metformin at that stage. We are not going to wait till the patient is diabetic to start therapeutic interventions.
Okay, thanks again, Professor Saliba, for your time. Now we move to the third speaker, Professor Wafa. Please, Professor Zaman, can you introduce him?
I received one very interesting question for first speaker, but I think I asked question at the end of speech of third speaker. So let me introduce Dr. Wafa Helmi. Her topic is very important, but very tasty, delicious.
I hope
enjoying food, enjoying food while losing weight. It seems impossible. And the second part of topic is the challenge. Really, it is a challenge. So how we will have to see how you proceed and tell us the tips.
Okay.
Dr. Wafa Helmi is the Director of Clinical Nutrition Department, Dubai Health Authority, with over 30 years of expertise in providing clinical nutrition support in DHA. She has written and co-authored numerous publications. Amongst so many awards, she also received prestigious Sheikh Hamad Award and Excellence in Healthcare Award. So, Dr. Wafa Helmi, please.
Thank you. Thank you very much. First, I would like to thank the committee and who have done such an excellent conference for today's, the IDF MENA. It's beautiful and the speakers are amazing. The talks were super. I'm just gonna, I hope I will give a fruitful talk. Enjoying food while losing weight and the right diet for pre-diabetic. We all knew that pre-diabetic is reversible and we can prevent it or just slow it if we have done the proper lifestyle. Now, in most cases, we don't need medication for pre-diabetic, and all what we need is to do the right diet plan. Additional to the healthy lifestyle, and that was most of our speakers have highlighted this more than one time. Right choice of exercise, avoid smoking, delegation, but the really important key is patience. And there's no single best diet plan for pre-diabetic or for diabetic or for any person. If you ask 100 people, what is the best diet? He will give you 100 ways with 100 answers. And they might be all correct. So it depends on what? It depends on their tradition, what they like, how they control it, and most important, their compliance and the way you convince them to shift their lifestyle to do it in a proper way, and because they're gonna live with it. It's a lifestyle thing. So extra pound among the most significant modification risk factor for pre-diabetics. and diabetics. And pre-diabetic plan is to choose how to maintain the healthy weight and the healthy BMI, and to avoid any kind of risk. And we all know that just reduction of 5% of the diet really can help you to maintain of the weight, can really help you to maintain your health in a good way. Aside from the weight, certain nutrients are linked with to improve the health and lower the diabetic risk. For example, increasing the consumption of fruits, vegetables, beans. They are and whole grains instead of refined. Choosing olive oil can really lower diabetic risk and limit, of course, the simple sugars and the sweets. Now, if you don't follow the diet plan, and it will not work, any diet, no matter how nutritionally perfect, needs to fit your lifestyle. So we have to include food that you love to eat. And this is very important, because if I put a plan as a clinical dietitian for you as a patient, and something that you don't like, and something you hate, and you don't love it, you will not comply, and you just follow it for one day, one week maximum, and then you'll go back to your way. We allow people to indulge sometimes in their special occasions, and so they can satisfy their occasional craving and fit the parties. And this is how we do it. We calculate what they want to eat during this occasions, so they can enjoy food, and especially the food they love. Try to teach them how to cook and to give them the ingredients. And I have a very successful stories with my patients, whom I just be with them in their recipes, just alter them a little bit. They love to have this kind of food. What we can do to make it healthier, plus the amount that they really need. We really require to spend an amount of time in the kitchen that they want, and give them the ingredients that they want for all the recipes, so they can alter it. The pre-diabetic plans helps really to control the blood sugar, and really give you a longer period of time, control the HbA1c if we follow it in a proper way. And a healthy diet for pre-diabetic doesn't necessarily need to be low in carbs. According to the US News and the World Report ranking, there's 2 types of diet for pre-diabetic and high cholesterol in 2020 that they are top of the rank, which is the Mediterranean diet that have a lot of fruits and vegetables and olive oil is there, and the DASH diet, which is dietary approach to stop hypertension. These 2 diets really have helped pre-diabetic because of their varieties, because of their, let's say, a lot of lists that they can have to choose from it of what they like and what they don't like. Now, people think that when they cut carbs, this is something good, but the amount of carb consumed in the meal is what really influences the blood sugar. The diet filled with refined and processed sugar, that can, of course, we all know that's the reason of spiking in blood sugar. But if we have the good carbs or the complex carb with good amount calculated according to the calories, it will really go smoothly. And not only that, if you eat calories, need more than what you need, all of it will be stored as fat, and that can cause the increase of weight, which is remained in the belly, that cause the insulin resistance to happen. So the pre-diabetic plans are really designed to help to lose weight and to improve the sugar of all over our patients. And each plan, of course, depends on the activity, on the age, what kind of habits they have, and it ranges females and males from 1,200 to 1,400, and you can add more snacks, healthy snacks, if the patients need more calories. And we make sure that they have plenty of water, They have good check with their doctors. We modify the diet to meet their preferences and their dietary needs. And we give them like a list, a lot of lists that help them to choose the good nutrients. And these good nutrients goes with the examples on life of food, what kind of food that meets their nutrients and their preferences as well. And we plan for them a sample like this one, a 1,200 calorie sample from day 1 to day 7, and we just go with them even with the recipes according to what they need. This is a sample for 1,400 calorie, and then we take this and we try to show them samples of the exchanges. When we talk about 16 calories, which is 3 grams of carbs, 1 gram of protein, how it will look. We show them by their own eyes. When we talk about 100 calories, which is 23 grams of carbohydrate, how it looks. Half cup of rice, half piece of corn, 1.5 piece of bread will give you this much of carbs. So we show them, so they will know exactly the sizes of food they have. And not only that, when we give them, we try to plan it this way, that they know breakfast, lunch, and dinner, how it will look. And it looks nice, it looks tasty. Diet doesn't mean that it is tasteless, food without a taste. Look at this when we go for breakfast, and every day we try to give them, we don't repeat the same food. We take the list from them and we tailor it. We tell them, okay, this today your breakfast is that, tomorrow your lunch is this, and the dinner, and it works. Look, different type of patterns that we give to our patients to meet their, first of all, culture, needs, preferences, likes and dislikes, and the food they love, they will comply more. We try to use the model of different models that meets our patients. Either we go with the glycemic index for the very educated patients, because we all know that glycemic index it's a tool that helps to show the particular food that could affect the blood sugar. Sorry, and the food that they are high in glycemic index raise the blood sugar faster. Food ranks with lower on scale effect on the blood sugar spike. Having fibers also lower the glycemic index. Processed food increase the glycemic index, and we explain it to them. Sorry, and we have a table that we take it and we tailor it and we show them how to do mix and match with the food that they can take from something they like in order to meet a low glycemic index. Also, if they didn't like that, we have another tool, the food portions. The food portions, we go by food sizes. We teach them how to do the food label, how to read it, how to list their food according to what they have. There's a recent research showed that sorry, have a lower carbs diet, less than 40%. Similarly, like greater than 70% have a bad impact. But if you go from 45 to 65%, according to their calories need, according to their activities, then the individual carbohydrate needs will vary based on the person's structure and activity levels. So the dietitian will put the specific need accordingly. Also, we encourage them to have more fibers because it will let them feel fuller. It helps them to avoid the crash of eating high sugary food, and it really gives a big boost of energy. And we show them the examples of where to find this food from the things they like. Cut on sugary drinks, because actually they don't have any kind of nutrition value, and water always is better choice. We go for, if they didn't like the sizes or the glycemic index, we can go for the plate. And actually, I found one of the nicest tools, easy to understand, is the plate method, where I can explain to them how they can have their own food in a better way, explaining that half of the plate food vegetables and the other half between the proteins and the carbs. And we tell them how to that the carbohydrate break down into glucose, and we explain it to them, and we try to show them how to calculate the amount of carbs they are having, and also educate them to read the food labels and how to have the serving sizes and the carbohydrate content. The dietitian also recommend to have something called, if not the portions or the plates or the glycemic index, then we go for the choices. One choice equals 12 grams carbohydrate or 15 grams carbohydrate. And we teach them how to take the choices from fats, proteins, and carbs to meet their calories intake in a healthy way. Now, with actions we need to do for the pre-diabetic patients to enjoy their food. First, we have to make sure that they are moving, get their body moving, and instead of sitting with their kids or others, especially now with COVID, most of the people at home. So we have to make sure that the activity is there even at home. Losing a small percentage of the total weight, even 5% can really help them to maintain and delay of having diabetic if they are pre-diabetic. And always not to forget the schedule for the physician. Improve their diet by the different types of diets and ways to educate the patients according to their understanding, their comfort, let it be in their comfort zone, so you will have the best of your patients, get a good sleep, and this is what we advise, and let them believe that they can do it. Not only believe in you, but believe in themselves. Because if they believe, they can take the action of helping themselves. The takeaway message of that, pre-diabetes can develop into diabetes if the person doesn't really care of their diet or their exercise and regimen. Taking the right action of the person is, and give them the choice of choosing what kind of diet they like. Because as I said at the beginning, there is no one-size-fits-all diets for pre-diabetics. What they like, how they can cook their food, because they have to enjoy the food they are having. Always colorful and always tasty. Diet doesn't mean that it is tasteless. Diet means healthy food in a very delicious way. Cook it in a very nice way. And always you have to go for the doctor for your feedback and review all the time. As I said, the pre-diabetes is around 1 to 3 of the people. You have to go eat healthier, lose weight, exercise, and check your blood sugar all the time. I end my talk with this slide, and these are my references. Thank you very much. I have to run because I'm the last one and we are already over time.
Thank you very much, Wafa, Dr. Wafa Helmi. Before for your excellent talk, delicious, tasty.
Thank you.
informative. Now, before I hand over mic to Professor Mohammed Sendid for his final comments, I have got few important questions, a lot of questions, but I've chosen few. Number one question is from first speaker, Professor Abdul Majid Sharabi. Is quantity of olive oil important even in diabetic? Because volume of olive oil, calorie-wise, it contains more calories than sugar. So how much olive oil may be taken for diabetic patients?
Sure. We know because it's lipid. We have 9 kilocalories per gram. We did some studies about olive oils in our department, and we give almost one average spoon a day. It's sufficient. 10 to 20 grams of olive oil per day it's correct. We know that for obese patient, it's we have to be careful. But in this measure of 20 grams per day, it's very beneficial for health.
Thank you. A second question, which almost every patient asks to diabetologist, is how many fruits per day may be taken by diabetic patient? This is by Dr. Wafa Hilmi.
First of all, and I think Professor Abdelmajid will agree with me, I want to comment on two things. First, on the fats, we calculated according to the, as Dr. Abdelmajid said, from the total calorie, 30% from the total calorie, 7% which will be saturated fats, and the rest monounsaturated fats, distributed according to the diet needed per day. Now, for the fruits, again, it's like anything. We have to measure the total amount of calories and distribute the carbohydrates according to the total day, breakfast, lunch, and dinner. And we add the fruits with breakfast, lunch, and dinner. And we always prefer to have it as a real fruit, not a juice, so they can benefit from the fibers. So they can have with breakfast, they can have with lunch, and they can have with dinner. Or if there's no space for that and they prefer to have lunch, as I said, it is tailored, we can give it as a snack for them instead of having it with lunch and dinner.
Good. The third question is, any role of intermittent fasting in curbing prediabetes is part of weight management? Any data to support this, please?
Any of the physicians can answer, but I'm not very fond of intermittent fasting because I saw some of my patients who have benefited for a limited time and then backfired on them. So again, it is individualized, and I think it should be for a period of time and then go back to another, let's say, a balanced way of calculations for the diet. As I said, Mediterranean diet and DASH diet were ranked on 2020 the best for pre-diabetic patients. And for diabetes, we go for carb counting and sometimes the glycemic index. So I don't know whether Professor Saliba or Professor Abdelmajid or Dr. any of them have any other comment on that.
Yeah, it's very interesting. Are you hearing me?
Yes.
Very interesting what you're presenting. And in fact, the problem with most dietings, any diet, initial diet that would allow the patient to lose, as we said, at least 5% of their body weight is beneficial. The big challenge is the long-term maintenance therapy, which is the big problem in most diets. So when we go into artificial dieting, now it's very much in the fashion, the ketogenic diet, the intermittent fasting. All these are giving fantastic results. I have a patient, wow, I can't believe it. The problem, I told them, we don't want to end up with the yo-yo dieting, which after a while, they get back to where they are. And the big challenge for anybody, dietitians, doctors, is to try to keep at least not allowing the patient to regain the weight loss. And this is where we have to introduce mostly kind of lifestyle changes, insist on this regular exercising, etc., and go back to a more balanced diet that can be maintained for a long term.
That's what I exactly said. When they have good results with intermediate fasting, as soon as they stop, they go back to whatever they had. They pick up all the way they lost.
Exactly.
So maintenance is the key, as Dr. Saliba said. Yes, I agree.
Yes, last question from Dr. Wafa Hilmi.
Yes.
And it is important for during fasting Ramadan. Please do fruit date. Have high glycemic intakes. How much dates may be taken during Ramadan or otherwise date?
Now, as soon as they break their fast, they can have those one date to break their fast, because we need that because we teach them how to do it. They break their fast, then they go for the prayers, they come back, then it is absorbed. It have a good, let's say, effect, because you know that it has the chance to go high after 16 hours of fasting. But to have them more than that, it have to be counted within their meal. And with the food, as I said, glycemic index, it will be high, but when you take it with something low, it can be medium glycemic index. So if we will go for that glycemic index, we have to teach them to mix it with something that it is low in glycemic index. Then when they take, like, for example, tahina, if they take it with that have fat, the impact on the blood is less. It will be medium glycemic index. That means it doesn't elevate the sugar very fast. But again, type 1 different than type 2 different than pre-diabetics. Each one of them have its own regimen to do it. And each one of them have the way of eating and calculating the diet for that. So it's...
Thank you very much. Thank you very much for your very, very nice answer. I congratulate all the three speakers for their excellent, elegant, fabulous talks. And now I hand over mic to my boss, Professor Mohammed Sended, for final comments.
So because time is short and we are late, and before leave the screen to the chair, Professor Jamal, to conclude the Congress, I would like to thank Professor Abdelmajid, Professor Noad Saliba, and Dr. Wafa for this nice session and the amazing lecture. Professor Jamal, please.
Thank you, dear Sandid, dear Zaman, Professor Saliba, Professor Abdelmajid Shraibi, Professor Wafa Hilmi. Hello, everyone. Dear friends and colleagues in MENA region and over the world. Because we finish with 20 minutes late, our closer session will be very short. As president of IDF MENA region and at the closure of the first MENA virtual Congress, I would like to express my warm thanks to all speakers and moderators for the quality of their talks, to all participants from different countries who were more than 1,800 attendees, also for all persons who has participated to the success of the meeting. My deep thanks go to Professor Bolton, IDF President, and Professor Akhtar, IDF President-elect, who has honored us, to the scientific committee and his president, Professor Mohammed Hassanin, for all the efforts in the choice of the topics and the quality of the speakers. My warm thanks for all members of Amber event for the professionalism and the quality of their work. Also, pharmaceutical companies, Sanofi, Servier, Merck, and Abbott for their support. At the end of this meeting, with more 670 participants, I hope that this first virtual IDF MENA Congress was up to your expectations, and I want to announce that all lectures presented during the meeting will be available on the platform for 1 month. All attendees will receive the certificate of participation. Thank you again, and see you soon on monthly Scientific MENA Blue Circle webinar. Good evening.